Right?
Your friendly face.
Okay, good morning, everybody. And I just want to let you know that this nice weather that you're having here, we brought this from Texas, okay? And actually, to be honest, in Texas, starting about mid-May through mid-August, it's about 100 degrees. So Celsius would be in the 30s, definitely. So this is even temperate by our standards. But I have to tell you, yesterday when I got off the airplane and walked outside, I was amazed at how nice the weather was here. And the other thing I noticed is that do not take a cab from the airport to the west side, because I didn't have any pounds, and the cab driver assured me that he would take a credit card. And then when he told me it was 85 pounds to get here, I'm like, what? 85 pounds? So needless to say, I had to do a quick exchange rate because the credit card machine didn't work. And now I don't have anything but a US 20, so I'll work with Nora on that. But anyway, my name is Mark Lavagnac, and I'm the president of DAVA Oncology. And DAVA is a physician-focused patient recruitment company. So it's kind of a mouthful, but we felt as though 8 years ago when we started the company is that there's a better way to educate clinicians and investigators on clinical trials to make sure that they're up to all the data, understand all the information to offer it to their patients. And in the United States, probably not here in Europe, there's a lot of patient recruitment companies that focus on the patient. But cancer is such a devastating disease that we really focus on the physician, making sure that you know all the cutting edge information about the trial as well as the standard of care. And what's intriguing about this particular tumor type is that I'm old enough to remember when gemcitabine was approved in the United States and Europe. So that was 96, 95, 96. So it's been almost 20 years since we've had active agents that are showing promise in terms of efficacy. There's been a lot of dead-end trials, but now finally we're starting to see drugs that are actually effective. And I think ASCO will even show us more drugs that are going to be effective, not just in the frontline setting, but the second-line setting. So a lot of change in the treatment of pancreatic cancer. Now, this trial, particularly the Maestro trial, has hit a milestone. So just as of yesterday, we're halfway accrued. So congratulations to all of you. So out of the 660 patients, 330 patients have already been enrolled. In this room, this is a pretty productive room. So this room has accrued 20 patients, which is almost 10% of the overall accrual in the European Union. So pretty amazing to all of you. And we have one of our most prolific investigators, and Radmila, I don't want to call you out, but I'll congratulate you on having 8 patients enrolled. So pretty fantastic, definitely. In fact, everybody here is enrolled. Everybody's open. Some of the sites have not enrolled yet, but most everybody has actually enrolled patients, right? So think about that. If there's a little competitive spirit here, the European Union is definitely beating North America, and I think you guys can do actually better and probably finish the trial. So as a take-home message, we think the trial will be done by the end of the year, probably even earlier. So I would probably give it 6 or 7 months. We're enrolling right now at about 50 patients per month, and that's globally. So we've got, like I said, about 6 or 7 months to finish. And that means that every site, let's say we all were at even, let's say we're all at 0, every site needs to put on 3 or 4 patients in the next 3 to 6 months. So if we can find out what the right patient is for your practices, that would be a realistic goal. And today, although we're going to talk about the science and the protocol and how the landscape has changed, we're really going to try and identify the right patients for the trial. Okay? So that's really the goal. And Nora and I always say, and Nora Koo is my accomplice here in terms of facilitating. Nora's much younger than I am. So we do this together, and we always say that 50% of the time we should be talking, the other 50% we really want to hear from you. So it's a very facilitated meeting, and I think what most people really get out of it is finding out how their colleagues treat patients in this disease. That's one of the unique features of the program. So we have got actually 8 attendees today, which is a perfect meeting. We usually shoot for 8 to 10. Representing 5 countries, so 3 sites from the UK. This side of the table, we put you all together because we know you don't like to stay in the right side of the table. We have investigator from France, 2 from Belgium, We've got one from the Czech Republic, and then we've also got one from Israel as well. So we've got a very nice group. And as I said, 20 patients enrolled, and 6 of the sites are enrolling. So how are we going to get it done? Let me go to the first slide and say that remember your investigators. So everything we share in this room related to data, related to enrollment numbers, that should be confidential. But everything that we share in the room related to identifying the right patient for the trial, please go back and share that to your sites, right? We want to make sure that you're representing your site, that the coordinators, the nurses, and your sub-Is also know the information. So we are a confidential meeting, but some of the solutions to enrollment we definitely want you to share. And I'd like to introduce the team. So this is a collaborative effort. You're probably hearing for the first time about DAVA Oncology, but you do know your colleagues at Merck Serono, and they're here today. You also should know your colleagues from Covance, right, who is the CRO who's supporting the trial. Now, although Covance isn't here, they're obviously still very important to the trial. So let me go ahead and have the medical teams introduce themselves from Merck Serono, and that's Dr. Falk and Dr. Gimonet. So, Dr. Falk?
Yeah, it's me, Mark Falk. I'm a medic, board licensed internal medicine. I'm with pharmaceutical industry since a bit more than 10 years now. I've been educated clinically, mainly in oncology, and I'm one of the responsible physicians for the Maestro trial and for TH302 development at Merck Serono.
Very good. And Dr. Falk's going to talk today on the mechanism of action, because it's very unique, being a hypoxic-related drug, and then also the phase 2 data. So we'll have a nice background. And then Dr. Gimonet.
So I'm Jean-François Gimonet. I'm in the pharmaceutical company for a little bit longer than Martin. I'm an oncologist by training, and I'm the senior director in charge of, from a medical affairs point of view, of TH202, and located in Darmstadt in Germany.
Right. And what Dr. Gimonet didn't tell you is that before he came to EMD Serono, he worked for the company that developed nab-paclitaxel. So has a very strong history in the development of drugs for pancreatic cancer. Okay, let's have the operational teams, and I always like to introduce Dr. I'm talking to you, Dr. Gallman, Bruce Gallman, because Bruce is the general for this trial. So
it's not necessarily a promotion.
Yeah, in this day and age, I guess not. Right? But Bruce is really responsible for the trial. He is the clinical trial lead. So when it comes to questions, Bruce will give out his business card. He is really the person responsible for making this trial go, and it's a complicated trial. We had a change somewhat in the standard of care, but he's responsible for really owning the trial and the accrual timeline. So I'll let Bruce introduce himself.
So Mark does call me the general, and he's very kind. He lets me believe I'm the general, but that's not really true. I'm Bruce Gaumont. I am the clinical trial leader located in Boston, Massachusetts with EMD Serono. And as Mark mentioned, my focus is everything operational. And I'm here to make sure that you guys have what you need in order to run the trial appropriately and in the most efficient and effective way. So I will leave you my card so that if you have any questions or concerns or anything I can help with, always feel free to contact me directly.
Very good. And this is our 7th workshop in Europe. So we try and do them back-to-back in cities. We've done 2 in Paris. We always do a Friday afternoon, Saturday morning. We've done 2 in Madrid. We just finished about 3 weeks ago 2 in Berlin. We've got 2 here in London, and then we finish in July with 2 in Vienna. So if some of your colleagues would like to participate in these workshops and you've been here, please have them sign up. The invitation just went out not even last week. Okay, if you like it. All right, let's have Simon Bracewell. I'd like to have you introduce yourself as well.
Okay, so my name's Simon Bracewell. I have met some of the people around this table already, but I'm the site relationship and operations lead for the UK, Ireland and Belgium. I'm part of a team within our global clinical operations group who are essentially the face of clinical research within individual countries, and our role is to help support you as the site and also to help support the CRO to make sure that everything runs smoothly with the clinical trials. Fingers crossed, touch wood for luck. So,
fingers crossed. So far, so good.
So far, so good, yes.
Yeah, very good. Thanks, Simon. And then two of our colleagues at Dava Oncology, Gregory Pines, right, who's in the back there. I think you all know Gregory. You probably got many emails. He's also the one who picked this beautiful hotel. He can tell you all about it. Totally redone, scrubbed from the inside and rebuilt over the last couple of years. If you want to see any of the members of Parliament, just go into the little bar area. They're all there. They should be in session, but they're at the bar. Actually, what do they have there, Gregory? They have a little bell, right, to let them know.
If the House of Commons is looking for a vote, rings so that they can go back.
A lot of activity. Definitely worth a tour. And then Agnes Nemeth, who is the project lead for the Maestro trial on behalf of Dava. So you've got a full team here. So let's talk a little bit about the goals and objectives. And I kind of always like to make sure everybody understands the key messages around the trial. And I think the most important thing is that the landscape is changing. And we're very lucky to have Dr. Xu here to tell us about that changing landscape and what's happened since 1996, 97 up to 2014. And it's very interesting. We actually had a side conversation. No one ever talked about second-line trials in pancreatic cancer. You never even got to second-line therapy. Now, there's actually data that'll be at ASCO talking about second-line, and we're finally trying to turn this disease into a chronic disease. So there's no right or wrong choice for frontline therapy. There certainly isn't for second-line therapy, but at least we now have options for the patients. Dr. Falk is going to tell us a little bit about the mechanism of action for TH302, as well as the phase 2 study. And know that TH302 is being developed in many different tumor types. So they have a completed soft tissue sarcoma trial, data to be reported sometime next year, right? We obviously have a very active pancreatic trial that will complete this year. And they are just starting a 440 patient non-small cell lung cancer trial. So this is a product that's being developed in many different tumor types with a very, very large clinical development campaign. So it's good to know and understand the mechanism of action. Whether or not you use that with your patients or just use it internally for your own knowledge, I think is important. We'll then talk about the phase 3 trial design and address any solutions or challenges specific to the protocol. And Bruce Gauman will lead that discussion. Our goal is not to go through the protocol like an investigator meeting, but highlight some of the areas where we know now, after half the patients enrolled, that could be a little bit confusing, just to help you and share some of the ideas that many of the practices have. We obviously want to optimize enrollment. We really want to get this trial done this year. I think it's achievable. We're at 330 patients halfway through, and our goal is before December 31st, but I have a feeling with the current run rate that we'll finish before the end of the year, right? And then have data in the near future. So here are the numbers. This is confidential, right? But we're going to share it with you. So Europe has 104 sites open, 269 patients screened, and 183 patients enrolled. So pretty amazing. Very excellent effort by the European Union. North America, 45 sites, 143 patients screened, and 87 patients enrolled. Now, it was very interesting. We started these workshops in the United States. And remember that nab-paclitaxel had data last year, but the actual FDA approval in the United States wasn't until September, where you could actually use the drug and be reimbursed. I know there are different countries will reimburse it at different times. So we were able to maintain the enrollment rate for the trial, even though we had somewhat of a change in the enrollment rate, just by identifying the right patients that you wouldn't put on doublet therapy versus single agent. So one thing for this trial, because the randomization arm is gemcitabine alone, you've got to get comfortable with gemcitabine as an active agent if you're randomized to that part of the trial. You may get the combination, but you may get gemcitabine alone. And we'll talk a lot about that today. And then other, I always hate it when they say other, but other is Australia, the Middle East, Russia, Japan. That is a very diverse other. But you can see here 27 open sites, 78 patients screened, and 60 patients enrolled. So again, 50% enrollment, pretty amazing. And I think we're off to a great start for the trial. So how are we going to get it done? I'm up here right now talking about goals and objectives. The next thing I'm going to do is go around the room, and we've actually asked all of you to put together one slide about your site. And the goal there is really just tell us who practices in your sites, what's your experience with pancreatic trials, what do you currently use in the frontline setting, and any challenges that you think are occurring right now that you'd like a little help with. We just want to hear from you how your site is actually treating these patients. Then what we do is it's interactive, so we do cases throughout the day, which keeps it fun and upbeat. And these are cases that you've given us, and we've got over the time doing these workshops. So Dr. Noriku is going to tell us and give us our first case, just to kind of feel how everybody's thinking about these patients. Then we have Dr. Shu talking about the advances in pancreatic cancer as of 2014. We'll do another case. Dr. Martin Falk will talk about hypoxia and the development of TH302. We'll do a little question and answer period, make sure everybody understands it. It's very interesting. In the United States, we see a little more of the MOA discussion with the patient. Not as much in Europe, although this group may be different. So it just depends on how you use that information, and we want to make sure that you're comfortable with the information as well. We'll take a break. Then we'll talk about the phase 2 data. Dr. Falk will take us through the phase 2 data, which is very promising. We'll do a Q&A. We'll do another case, and each of these cases are different because each one brings up a particular issue that may be identified in the protocol. Bruce will talk about the trial specifics. Nora will talk about managing the patients, the importance of dose intensity, and also skin reactions. This is a different skin reactions, very manageable, but we want to make sure that we give you the tools to manage it. We'll finish with cases again. We'll talk about identifying the right patient, and then we'll end with challenges and opportunities. And the workshop is designed to be 5 hours, but I think with a group of 8 people, we should be done in about 4.5 hours. So our goal is to get you out before 5 o'clock. Okay. So let's start with site introductions. Does that make sense to everybody? Sound good? Yeah? Okay, very good. So, Kai-Keen Shu, let's start with you. You've already been to one. So Kai-Keen has actually been to one as a participant, and now he's coming as one of our lecturers. So all of you, there's like a magic number under your chair. If you get it, you come back as a speaker. It's completely random. Completely random. So be prepared. But Dr. Shu, if you tell us a little bit about your site here in the UK, that would be great.
Yep, so I'm not PI for this trial, but I work very closely with 2 medical oncologists, professors, and also clinical oncologists who mainly deliver the chemoradiotherapy. We have a lot of registrars and clinical fellows. We see a lot of pancreatic cancer at every stage. In terms of percentage of resectable metastatic, I really don't know, but we have done a lot of trials in pancreatic cancer. In terms of our strategy, I mean, I'll do the overall kind of landscape, but kind of our strategy has been always think of trials first, but in a fit patient, we would give them all options. So that would be FOLFIRINOX, GEM. Now we have GEM, nab-paclitaxel on our CDF, which is our Cancer Drugs Fund. We can give modified FOLFIRINOX like FOLFOX, and of course trials. In terms of local advanced disease, we do give FOLFIRINOX for local advanced disease, but we also use this kind of scallop regimen, which is GEM-CAP, and then chemorad. But there's some interesting data about from the Lab 07 study, which maybe chemorad isn't so good. Mm-hmm. I won't talk about the adjuvant treatments. We had SIV, but when I did Paris, we hadn't actually enrolled anyone. We were various delays, but we've screened quite a few, enrolled one, and we can talk about that later maybe.
Yeah. Did you, I remember when you came to the Paris workshop, you had an active frontline trial, which is now subsequently closed, or is it still active?
The active frontline trial for first-line metastatic?
I thought we had one first-line metastatic.
No, I mean, we can talk about it. I mean, there's a academic trial coming out of Cambridge called the SEED trial. Yeah. But that may be hard to recruit now. Nab-paclitaxel's on the CDF, but that's a trial basically looking at Abraxane GEM together, or Abraxane on day one, GEM on day 2. But that's going to take 2-3 months to open at UCH. That might affect recruitment. I don't know.
And you've got now in the UK nab-paclitaxel is approved and reimbursed? I know it hasn't gone through NICE. NICE will still take another year or two.
Reimbursement is not really what we call it. I think we just say we apply to the what we call the Cancer Drugs Fund.
Right.
So the David Cameron £200 million pays for it. And the most importantly though, we can only give it in first line. So we cannot use it in second line. So we can't give someone FOLFIRINOX or a trial and then nab-paclitaxel second line.
Right. And what about for locally advanced disease? Is it just metastatic?
Yeah.
Yeah, it's
Just
just and it's also just metastatic.
It is just
Yeah,
metastatic.
it's not for locally advanced inoperable. It's you've got to have measurable metastatic
You
disease.
do.
I think that's right.
Yeah,
that's right.
It is.
Yeah.
Yeah, very good. Very good. Sebastian, let's hear from you. Obviously very similar in the UK, but would love to hear about your experience. It looks like your SIV was just done in February.
Yeah,
right?
that's right.
So you are
yes.
open. Okay.
Not been long open. We have screened some patients actually.
Good.
So I'm one of two consultants, and there's a couple of registrars as well. We serve a population which covers up to 2 million people.
Wow.
We see quite a lot of patients a year. The figure of 80% I just drew from the average that comes through the HPV-MDT, most by definition being unresectable.
Yeah, 80-20.
metastatic. Yeah. Prior trials, well, we've been involved in all the big national trials, SBAC, etc., TELAVAC, Scallop, we were the recruiters in, and we're also on SIEGE, etc. And the chemotherapy that we use, yes, gemcitabine for those with a poorer performance status.
Mm-hmm.
We do use nab-paclitaxel. I was actually the physician that made the presentation to our Cancer Drugs Fund, so I've been involved in getting that available.
Very good.
And FOLFIRINOX. So we're screening. We haven't enrolled anyone yet. We've just not. They come like buses. It's
Yeah.
a phrase we use in England, and we've not had a lot. But I think there are issues as well around the availability of, we're talking PS 0 to 2 in this trial, aren't we, for metastatic?
Exactly.
There are potential alternatives, and I'd be interested to hear what we talk around that. But I'm also very conscious that it's not that, it's important to stick patients, as you said, onto trials.
Right.
We need to get more available, and
Yeah.
we need to be trying to turn it into a chronic disease. So very keen that we should be involved in all
Yeah.
trials where available.
And we know that's not an uncommon theme that we hear. We want to prioritize clinical trials, but you have to be comfortable with that, with gemcitabine being a single agent as a comparator. And so you have to look for the right patient. And it seems to me now the change is that for real healthy patients, you're looking at a doublet or FOLFIRINOX. But a question before we get on, how are you differentiating giving the nab-paclitaxel doublet versus FOLFIRINOX in the frontline setting?
Good
What's
question.
that? Because that's a tough one.
Well, for me personally,
Personally.
I think there's a couple of things. Certainly, if they're PS2, they're not going to get FOLFIRINOX, 0 to 1, without question, for FOLFIRINOX. If they've got pancreatic head tumours with stents in situ, then they're more likely to get, I would tend to veer towards paclitaxel containing combinations as opposed to FOLFIRINOX. Obviously, the trial, the FOLFIRINOX registration trial, there was an excess of tail tumours in that group. We do tend to stretch the boundaries with FOLFIRINOX because we're not tied down by funding. So locally advanced, which we're doing a lot of these days, locally advanced plus or minus chemoradiation, there's a good response rate with FOLFIRINOX, and you can get some of these patients, you can get some of them to surgery as per the sort of MD Anderson type route. So I wouldn't say there were defined criteria. It tends to be a little bit soft.
Well, it depends on the patient. Whether each patient is different as you come in and evaluate them.
Yeah, I don't know what everybody else's approach is. But
Yeah. And do you offer them a clinical trial in that setting? So if you had a patient who was relatively good performance status, you've got FOLFIRINOX, you have the nab-paclitaxel, you also have a
we have
frontline trial,
SIEGE.
right?
You see, that's the other thing. We've opened SIEGE, which I don't see.
Now, what is that?
Now, SIEGE is it's basically it's trying to explore the mechanism of nab-paclitaxel, how it potentiates, whether it potentiates gemcitabine or whether it has an action of its own. So it's looking at the delivery of nab-paclitaxel and either before or around gemcitabine as per the IMPACT trial.
Right.
So both arms actually get nab-paclitaxel, so I don't actually see it as something that's going to suffer by the availability of this drug on the CDF. It's trying to refine it, trying to work out whether there's a better way of giving it. So that would be a trial that we now have available in that setting. We don't have a FOLFIRINOX, but I don't think many people think that FOLFIRINOX is much of a backbone to build future therapies on. It's a tough.
Well, it's interesting because
although I know there's some French people here, so
yeah, exactly. We're getting Gerald needs
sorry
to tell
about
us pretty soon.
I use it.
Well, it's very interesting. Just from our experiences in North America, you can use nab-paclitaxel. They don't differentiate by line. So people are very, very interested in frontline treatment. Will a lot of times treat with the Maestro trial. They're monitored very closely, obviously, in a clinical trial setting, and then use nab-paclitaxel on the second line as they're trying to turn it into a chronic disease. But in the UK, you only get that option in that frontline setting for metastatic. So it just depends on the region. But this particular trial is, we'll talk about it during the day. It's only a frontline trial. This is your opportunity. If you don't get the shot at it, you're going to have a hard time using it in any other setting. It's just not, there's just not a clinical trial available. But there will be a combination of TH302 with nab-paclitaxel. That's in the early phases, right, Bruce? Eventually that will become probably a randomized phase 2 and a phase 3. But we realize that that is a backbone. And it's so interesting because it was Dan Von Hoff at the CTRC in San Antonio, Texas. Actually, John Eckhart, who's our chief medical officer, practiced with him. He actually developed gemcitabine, who did that initial trial, and it was really approved on quality of life. People actually felt better on the drug, which then tended towards a survival advantage. And then he also did the nab-paclitaxel trial. So 20-year difference, but also was the developer of that as well. So pretty interesting. But thanks, Sebastian, we're going to talk more about it too as well.
Hey, Mark, just want to jump back to Dr. Shu for just a second. Before the Paris workshop, you hadn't screened anybody.
Yeah.
And then after the workshop, you have one patient in. Do you feel that that workshop helped you to break down barriers or resolve some of the challenges you had in order to start screening and get patients into the trial?
No, because I think, like Sebastian, we're very pro-trial. I hope that came across in front of you. So we were just waiting for things to kind of get on so we could open the trial. So I don't think it really massively changed that we would give a good performance status patient all options. I think what interestingly, we've now been talking to our network. The Royal Free is a major hepatobiliary surgical centre, and they give a lot of, like MD Anderson and MKC, kind of reduced dose FOLFIRINOX upfront for PS2, and they have very good results of giving 80% upfront of all drugs, and they can get to an Arnold resection on 12 cycles, right? So, and I was at a Marsden pancreas meeting, as I said, where David Cunningham had sponsored by Celgene. We had Americans from MD Anderson and MSKC talking about the American experience of FOLFIRINOX and nab-paclitaxel. And FOLFIRINOX is still out there. I mean, UK use it a lot and still feel very comfortable, partly maybe because of the fact there's no CDF. I mean, you can give it, you can adjust it, and we don't seem to be so line averse. And the only thing I would say is that we had a guy called, I think it's Colin Weeks from Colorado, and he was saying, what is this? It's really difficult to say when would you give nab-paclitaxel versus FOLFIRINOX in a good performance status patient. And he said, a lot of it is patient choice, and isn't it good that we have patients have a choice? The other thing was it depends on your kind of how young fit mountain bikers hate neuropathy, and of course oxaloplatin neuropathy is a very different neuropathy to nab-paclitaxel, right? So nab-paclitaxel neuropathy, bad, you stop, it goes away relatively quickly, and you can re-challenge. Oxalopathins, can get better, it's going to get worse before it gets better the moment it starts going, and that has, you do tell the patients that, and they will have their choice of what they want to do. But I think it comes down to soft grey things. I mean, even
I think
David Cunningham said, in terms of, it depends what you are trying to achieve here as well. If a surgeon says, I want you to get the maximum response because I think it's acceptable, you have to probably go with FOLFIRINOX. Yeah, response rates are important. If you're locally advanced, then probably FOLFIRINOX, although obviously the trial was metastatic, but the response rates are good, and they are
better probably than the gem nab-paclitaxel
And any-
response rate. So if you're talking about getting to, and also, I don't know how you give it in France now, but we don't tend to give the bolus 5-FU.
Sorry?
Commonly, we won't give a
No.
bolus 5-FU, etc. So we'll do. It's been refined so that we
Right.
reduce the toxicities, and so if you can get that improved response rate, you can get into surgery.
Yeah.
That's
No,
local.
I agree. And if you really look at what we're trying to achieve with the Maestro trial, and you look at the power of the trial, if the trial is positive, you're going to see efficacy very similar to the nab-paclitaxel combination. So what's the nice thing about this trial is you do have two very neurotoxic regimens, right? Different, but both neurotoxic. You're going to end up with a regimen that doesn't have any neurotoxicity. So now you're going to have three choices, right? Still, I believe FOLFIRINOX always does demonstrate the best efficacy at full doses. We don't really know what the modified dose is. Got to throw that in. You guys are obviously all rounding up. I'm the pessimist, kind of round down. But at the end of the day, we don't know. But right now, if everything goes the way we think it's going to go, you're going to see efficacy very similar to the, and maybe it's better. We don't know, but we'll probably see something very similar. No,
Can I just
good.
add something? I mean, you guys have worked on the IMPACT trial where you allowed PS2 patients into what I would consider a more toxic chemo regimen than GEM and
Yeah.
PH2. I know it will be a major amendment to change it, but you have made it difficult for us because we cannot enter PS2 patient into this trial, and I can't see why we shouldn't. I'm not saying you should
The
now.
impact
but
trial did allow.
It did.
Mm.
It
Yes.
did.
And how did those patients do when
They did better.
They did
The
better.
subgroup analysis,
They did.
suggests there was a more marked advantage.
Yeah.
But that's because this disease is, as everyone knows, it gives such awful symptoms. Treat the disease. It's one of those situations where chemotherapy makes the patient feel better when it works. So if you get the response, it's the response really helps. So it's worth going for a bit of toxicity to get a
Yeah.
response.
No, you're totally right. And I think we see that over and over again in medical oncology. The sickest patients, a lot of times, intuitively you think you're going to make them sicker and they'll feel worse, but actually feel better. And that, we're not going to amend the protocol. The protocol is, we're 50% of the way there. You're going to find out. But I don't foresee that once the product is approved, once we have positive data, that you won't see people using in that PS2 patient performance stats. I'll tell you one story and then we'll go to Harvey. But when John Eckhart was working with Dan Von Hoff and they were trying to get gemcitabine developed, that whole quality of life thing came out of the phase 2 data when he was seeing a patient who was very sick with their disease. Probably, PS2 didn't really travel much, but this patient was routinely at their appointment every day, or every week on time. And the patient was late. And the patient was not just, 20 minutes late, the patient was an hour late. And when he finally saw the patient, he said, why were you late? You're usually so, on time, routine. He goes, I was out having fried chicken, at my favorite fried chicken place because I felt well enough to actually eat the fried chicken. And, Von Hoff, smart enough, said, okay, something's happening here because this person was not going to eat that type of food and felt as though could do that. So hence that quality of life thing that then turned into a survival advantage. But yeah, very interesting.
Well, the
sick
quality of
patients-
life was they didn't record any, did they?
Yeah,
Properly. They've
it
got a
wasn't quality of life,
retrospective.
It was a soft endpoint that got it. But thank God we got it approved. It is the backbone. Very good. Okay, let's move on. And Harvey, tell us a little bit about your site in the UK as well.
I'm one of the study nurses. Dr. Serena Hillman is our PI. We're a small centre in the southwest of England. Our it says gemcitabine, capecitabine. They're also increasingly using FOLFIRINOX for this patient. So I'm sure she would mirror what the two gentlemen have said.
Yeah.
We've screened one patient. We haven't enrolled anyone yet. We're actually hoping to screen somebody next week.
Yeah.
Or certainly seeing somebody next week that's promising. So fingers crossed there already. I think probably we would mirror much more the current discussion is really.
Sounds like you and Sebastian are very similar, both SIV'd in February. So really, you're waiting for that next wave, that next batch to come in.
It's the same thing. Yeah, we've had over that period we've had patients. We've probably had about 4 patients, but they get too sick too quickly.
Yeah. Well, that's the issue too.
Yeah.
And we're going to talk a lot about. You've got you've got a very aggressive frontline therapy in FOLFIRINOX. you've got the nab-paclitaxel. In some countries, we won't see there where Czech Republic doesn't have nab-paclitaxel yet. Israel, I think, does. Belgium, I'm not sure, right? No. France, right?
Yes, we do.
Nab-paclitaxel is approved. So trying to stratify in between those regimens, because now you've got, you know, FOLFIRINOX, you've got a doublet, you've got another doublet, you still have single agent as well. Interestingly enough, in the United States, nab-paclitaxel has kind of peaked out in its utilization. It's about 30%. And then FOLFIRINOX is not as high in the United States. It's more around 15%. The rest is either single agent gemcitabine or some other combination. We don't see a lot of gemcitabine, capecitabine combinations in the frontline setting. However, what will happen is if they do choose to use it, they'll use the combination until they see the rash. Once you get the rash, they stay on the combination. If not, you discontinue the capecitabine. So pretty interesting. Or not capecitabine. Erlotinib.
Yeah.
Erlotinib. Very good. Thank you, Harvey. Okay. We finished the UK sector. We're now going to France. So Geraldine, tell us a little bit about your practice. You've screened and enrolled 4 so far.
Yes. So I just arrived 6 months ago in the unit of Julien Tailleb, the PI. So it's not my patients screened and enrolled, but my colleagues.
Where did you come from?
I was working in another hospital in Paris. I just arrived 6 months ago. And so we are 8 physicians, and so far, yes, the first line we use is FOLFIRINOX, but now we tend to use gemabraxane, nab-paclitaxel, sorry, when PS2 sometimes, and so yes, we are very keen to use TH302, so we screen people, but I don't remember if all are metastatic or locally advanced. I'm not sure about that data, but yes. And yes.
In the site that you came from, was the trial open?
No.
Did you have other trials open at that site, or was it mostly non-trial type of patients?
Not trial, yes.
Yeah. So this site has a definite propensity to put a patient on a clinical trial and offer it in the frontline setting.
Exactly.
That's good. So how in France are you positioning the FOLFIRINOX versus the nab-paclitaxel on a clinical trial?
It's a PS status, yes. It's a performance status, first of all. Yes, it's the main point.
0's FOLFIRINOX, 1's maybe the patient selection.
Yes, exactly.
2's nab-paclitaxel. So where does Maestro fit in then?
I think it's would be very interesting in locally advanced because we don't have more to propose. So, but metastatic, yes. Julien Tailleb is keen to enroll because he believes in TH302. So yes, we are we want to use it even if we have FOLFIRINOX. For locally advanced, we use FOLFIRINOX too sometimes in good condition, but I think TH302 is a good option too.
And remember, there are different side effects as well. So I think you brought up the mountain biker neuropathy is always something that you're going to deal with in FOLFIRINOX as well as nab-paclitaxel, although different. This particular product doesn't have the neuropathy. So depending on the types of patients, you need to think about, you know, what may be the best option. But I'm glad you're offering a clinical trial as well. I think that makes a big difference. Good. Okay, let's move to Belgium. So Francois, tell us a little bit about your practice. I know you have a personal story, which is very interesting.
Oh yes, I'm sure some people from the UK will know the person I will talk about. But I'm working at a 1,200 bed hospital and got an area of about 150,000 people training there in the south of my province where I live. And we are actually 6 consultants, but 2 are mainly involved in pancreatic cancer. And the bulk of our patients is gemcitabine. We have a few FOLFIRINOX for people who have a good performance status. And we have actually also a few patients on nab-paclitaxel, but they have to pay it from their own pocket to use it in a second approach when they.
So in Belgium, they have to pay for it out of their
Yes, they do. Yes, I don't know if you have a special fund there again, but we don't. And Yeah, I'm sorry to tell you. We're talking, Nora, about difference between state. We have our own problems as well for funding people, for trying to treat people.
Yeah.
So it's not that difficult in our situation to propose that master trial, because this is the what we are proposing is already the same, but on top of it something else. That's what I wanted to say.
You might get the added benefit of the TH302, and you're monitored well. You also have the gemcitabine. You're paying for gemcitabine outside the United States, Bruce, or is it? A lot of times they pay for the commercial side of the drug.
As far as what we're supplying?
Yeah,
Yeah,
you're supplying the gemcitabine.
We reimburse for it.
You reimburse for it, which makes it nice as well. Very good. Any frontline trials open other than Maestro?
Not for pancreatic cancer.
Okay. Yeah. So is it any second line for pancreatic cancer?
No. What we are offering is FOLFIRINOX for those who are good performance status, and then we swap to gemcitabine. There's no second line available. So we are happy to be involved in that trial. Yes.
Absolutely. Well, and remember, we're only probably 5 or 6 months out, so we made it this far in a very changing environment. And that's why when we come to these programs, we're not looking for every patient. We're just looking for a select few. If over the next 6 months, if you're putting on 3 or 4 patients, if you find that right patient, that's enough to get it done, and then we'll have answers to the trial. And I think for those of you, how many people are going to ASCO this year? Raise your hand if you're going to ASCO. Okay, so Karen, you're going. Only one. How many are going to ESMO? Okay, that's what I figured. So you got 5 of you going to ESMO. But we're going to see even more data at ASCO and ESMO in the second line setting. Halozyme's got a product. Insight's got a product. There's going to be more second line trials as well. And you'll see that Merrimack has one as well that showed data. We'll see that at ASCO. So this will be an exciting day. In fact, I don't know, Martin, you tell us, if we finish on time, data break for pancreatic cancer would be when? Just intuitively based on the timeline for the protocol.
You mean the data out of the Maestro trial?
Yeah, when would you see data? Probably 2000 and...
Next year.
Yeah,
Somewhere next year.
2015.
Winter of 2015.
Yeah, which, that's not that far away.
No, it isn't.
Very good. Thank you, Francois. Karen, tell us about your experiences. You actually have 4 patients, right? Or you, 4, right? Screen 5 and enroll 4.
I didn't fill out that. Did I fill?
That is very impressive, by the way. Screen 5 and roll 4 within a week.
we tell you that you fill it out. It's a test. It's a test.
You are the winner, in fact. Look at your
Look under your table. Look under your chair. You may have that sticker.
Okay, so yes, we've got 3. Well, in Belgium, it's usually the gastroenterologists that treat GI oncology. So we've got 3 gastroenterologists that really treat GI oncology, including pancreatic cancer. The pancreatic cancer patients seen per year it's 25 to 30 for us, being the metastatic or the locally advanced, because I don't know the exact numbers of the surgical unit, and we kind of recruit in the area for surgery. So I don't know how much of them they, because 25 is our patient number. We've got this one trial now active, and we're in discussion about 3 are about to start, and in discussion for a 4th one.
In the frontline setting or
in different settings, in adjuvant
settings,
setting, in different lines, because we always try to have not too much trials that compete. So
you always want to have a frontline trial if you can get one. I know it's getting more and more difficult with the agents that are there, but having a frontline trial is important.
And as Francois said, we have gemcitabine as a first-line chemotherapy. You cannot have nab-paclitaxel outside of clinical trials or patients paying for it themselves. And we tend to have, we don't use FOLFIRINOX that much either. It's because oxaliplatin and irinotecan are not reimbursed for this indication in Belgium, so we have to ask it, and we ask it for other indications as well. And being an academic hospital, we sometimes need these medical need programs more than others, and so we kind of not used. We decided not to use the FOLFIRINOX that often for pancreatic cancer. I tend to ask a lot more oxaliplatin and irinotecan for gastric cancer, and so we don't have a problem in recruiting patients, although they tend to come by buses, like you said. We had a lot of them until February. Like we had a quick enrollment, I think, in about 2 months, and since then.
Yeah. Need the next batch. And sometimes, remember, at least in North America, sometimes the patients come with the article, right? Sometimes they come with the paper and say, this is what I want, doctor, or what would you do? So in your particular setting, I'll ask you a little different question. It's a little easier when gemcitabine is your backbone, but how do you explain the clinical trial to the patient? How do you say, you know, I can give you gemcitabine alone, but I've got the Maestro trial. How does that discussion work in your practice?
For me, this is an easy trial to talk about because they have they can either choose to have what we give in first line, or they can have the possibility of having a randomization to an extra medication added on top of the gemcitabine. So this is not a difficult one to talk about to the patients.
Are most people, though, scared of a clinical trial, or are they looking at a clinical trial as something that's, you know, cutting edge, if you will, or something new?
No, but we tend to have young patients. We tend to have patients that look for extra possibilities. So it's really not that difficult to talk about this trial.
Because it's different. Every site's different, and every patient's different, right? You know, as you're trying, sometimes you're talking to the patient, sometimes you're talking with the family, if they're a little elderly. And elderly, we'll talk about that. Elderly is not 50, okay? Just want you to know that. Elderly is now like 80 or 70, something like that. But I think, yeah, how you describe it is always important.
I think, when you choose to do trials, you know that you sometimes have to defend the trial which you may not believe in that much yourself, but because it's part of the deal, it's part of what you do in your hospital. You want to answer a question, so you have to find a way around certain questions or certain trials as well. But this one is a good question, so it's really not difficult to talk about it. And me personally, but it's because we don't get the FOLFIRINOX that easy and the nab-paclitaxel that easy either. But I think, like, metastatic pancreatic cancer is still a chronic disease, so I try to give patients one thing after another and try to keep them going for a long time. So I'm not that convinced, I'm not that angry that I can't get the FOLFIRINOX that easy, or the nab-paclitaxel either. So which makes it not difficult to talk about gemcitabine in a trial. So.
May I ask you, in the setting where a patient comes to you and says, I'm happy to pay for anything, what is your approach then? So I understood in the situation where clinically you may have limitations on what you are offering because of insurance reimbursement or access to drugs or something like this. And clearly that may be different than other colleagues in terms of what's available. But how about the situation, if those were not obstacles, how would you interpret this
So if I would go for FOLFIRINOX, or if I would go for nab-paclitaxel?
Yes, where would those be in yours, as a clinician, just strictly, you know, as a scientist in pancreas cancer?
I wouldn't do it differently because of two reasons. I've got these patients that want to pay for everything, but when they start to use the drugs, and they are good, and they have to have the drugs for longer than expected, and it becomes a problem. So I'm not that keen on having patients pay for themselves. That's one. And two, I don't have much experience with FOLFIRINOX, and I don't have much experience with nab-paclitaxel, and I'm just not. I believe in the idea of having a good response rate in locally advanced and going to surgery. That's true.
Sure,
But in metastatic cancer, if a good response rate really has to give a big benefit in the end for me. Giving FOLFIRINOX in first line, okay, for a good response rate, has to add really something more than what you see these days. I mean, if I get my patients that are young and that are, you know, if I give them one thing after another, I tend to have a life expectancy that is even better than what was cited in the FOLFIRINOX trial. So I see no reason why I should change my practice or ask somebody really to start on FOLFIRINOX.
Yeah.
Karen, can I just ask, what do you offer in second line? So you give someone a gem, and you say you can keep them going. But in a young patient, what do you do? Because they progress on gem, and what are you going to give them second line?
I give them a platinum-based combination, so FOLFOX or cisplatin 5FU, or and they usually, well, we used to have, I don't know, third line or second line trials. I mean, the good ones, they go for 2 or 3 lines. And
Sure.
they live for 13,
We'll show you
14
some
months.
data too. Nora's got some nice data on second line trials with FOLFIRINOX or combos of FOLFIRINOX.
I've got it.
Ian's gonna
Yeah,
I'm
present
gonna
that part.
I'm just,
It's small data sets though, but like I said, I think we're just on the edge of seeing more second line data in this disease, and it just wasn't thought about. But it sounds to me it's a pretty easy trial. You said something very interesting. When you really commit to giving clinical trials as an option to your patients, there are some that are easier than others. There's some where your own biases are in there, but you still have to present it as an opportunity. And there are those patients who really want to be on a clinical trial. In the United States, certainly there are people come in looking for a clinical trial. And there's also those patients that come in with the article. And then there's the patient that says, doctor, you're the doctor, you tell me what you would do, right? And that's where the personal biases come out, right? Because you have to be, you're still a clinician, but they're going to ask you, how would you treat if this was your mother or grandfather or grandmother, what would you do as well? So I think that's important. But I appreciate the feedback, that's good. Let's go, whoops, I'm sorry.
Karen, you mentioned you have young patients. Do they ever ask about how the drugs work? Do they ever ask you about mechanism of action or?
Sometimes, but not really that much into detail, no?
Okay.
You can kind of work your way around the hypoxia thing for a patient to understand.
Yeah.
Okay.
Yeah, we'll talk about how to explain it. Some people explain it, some people don't. I mean, it just depends on the right patient, right? If you have a very sophisticated patient, they may not. You may end up treating one of your colleagues, right? And there may be a scientific interest. Other people may not. You know, the minute you start explaining it to them, you see the eyes glaze over, and they're not interested in talking anymore. But thanks, Karen. Very good. Let's move to the Czech Republic. And Radmila, tell us a little bit about your experience. You've already enrolled. Well, Screen 10 enrolled 8, open since the very end of last year.
Yes, I work in a university hospital, and actually the physicians taking part of the pancreatic cancer patients are usually physicians from the medical oncology unit, and it's about 5 consultants. The number of pancreas cancer seen per year is 20 patients per consultant approximately. The majority is, of course, metastatic of unresectable pancreatic cancer. The prior trials in pancreatic cancer on our side, it's more than 2. 2 is my own experience I took part in.
Do you have anything open in the frontline setting right now other than Maestro?
No.
This is the
This year it's the one. Okay. The first line chemotherapy regimen which we gave is usually gemcitabine. Minority of the cases we administer FOLFIRINOX also, but it's also for PS0 usually for the also younger patients.
Very good performance status patients.
Very good performance status patients.
FOLFIRINOX paid for in
it's
Czech
paid
Republic?
for them. Everything is paid. They do not have opportunity to actually pay themselves.
And
it's not possible.
The Taxol is not paid for as well?
No, it's not reimbursed in Czech Republic. I think we have a lot of patients because the incidence of pancreatic cancer is one of the highest in the world.
Really? Yeah. Interesting.
And
I don't know why.
We don't know why. But also our university center is very well known for the surgery, pancreatic biliary surgery. So a lot of patients from the whole republic get referred to the center.
They do.
So that's why we get a lot of patients.
And in your center is a multidisciplinary approach?
Yes.
Each patient comes in, they're discussed a tumor board on what to do,
There
whether
is
they're
a-
surgical candidates or not.
There is a tumor board, and so every patient actually is then also seen by the oncologist, the medical oncologist.
Okay.
If,
And it sounds like you're offering clinical trial to every patient.
we encourage them to take part in the clinical trial, and I have to say they are willing to cooperate. They are not against it.
Yeah.
And usually, if it's phase 3 clinical trial, it's
Sure.
no problem.
And based on your experience, now that you've got the 10 and the 8, were they mostly locally advanced or metastatic patients?
They were metastatic patients.
Metastatic. And any pearls of wisdom for those that are on therapy, even though it's blinded? I guess I really can't answer. You can't answer that question. It is blinded. But it sounds like you've had patients on therapy, on trial for quite some time as well. Maybe not. I mean, 5 months.
In the beginning of the trial, when we started, we had some patients who progressed very rapidly. And but now we have a few patients who are doing okay.
And are you following
without just
this-
any larger toxicities.
You're following the skin toxicity?
We don't see the skin toxicity.
Haven't seen. Okay.
Mm-mm.
Are you preventing for it? Are you using
Yes,
the
we are
ice?
preventing. Yeah.
Because it is
But,
completely preventable.
What we see is the fatigue. They are really tired, like they have like a flu-like syndromes.
Mm-hmm.
That's what we see more often.
Okay. Yeah, very good. We'll talk a little more about that, managing. This is not really about managing patients as it is describing and finding the right patient, but the skin toxicity issue is one that we definitely want to talk about, and maintaining dose intensity. Okay, so Shlomit, very good. I should have done Dr. Feng, it would have been much easier. But tell us a little bit about your practice in Israel, and then that kind of ends the first session.
I'm actually a resident, so I don't have practice. I'm here to, I'm eager to study how a clinical trial is based and conducted, and this one in specific, and go back to my colleagues in Israel and share the experience. I work at a big university hospital. It's called the Sheba Medical Center in Israel. It's the biggest. It's got the biggest oncology ward, and in the GI department we have 4 consultants. We usually tend to give Gemzar and to patients who are capable. FOLFIRINOX, we started to give it more and more often.
Mm-hmm.
And I've spent the last year at the daycare, oncology daycare, and I'm really interested in studying about the side effects, the toxicity of the drug, because we're actually treating these patients. So.
Yeah, very good. So, and you opened in December, you screened one in January, and actually enrolled one in January. What about nab-paclitaxel?
I'm sorry, I don't have.
You have any experience with it? Because I think it's paid for. You can come in and request it as well. But mostly, so how are you differentiating the FOLFIRINOX versus single agent Gemzar?
For the how do we decide upon which just based on performance status?
Performance status, right. And it sounds like everybody's pretty comfortable treating a performance status 2 patient with chemotherapy. If they're, there's the performance status 2 going to performance status 3, and there's that one that's merging into 2, right? Very subjective.
It's an evolving picture.
Very subjective, type of criteria. Well, very good. Thank you. Thank you very much, everybody. I think you already are getting a feel for the differences in the countries where other options are available, different practices, some may not be available, how to describe the trial. And what I'd like to do now is turn it over to Dr. Koo. and have her go through the first case study, because this will be a dynamic discussion of an unusual patient. Every patient is different, and how you would potentially be able to treat that patient. Watch out for the lights. As soon as you get in here, you'll see about 5 or 6 different lights in your eyes. Yeah, that's Stan. You gotta come over here. There you go.
Wow. Okay.
Yeah.
Got it. Okay. So thanks everyone. I'm a medical oncologist by background and training, and so I come to you also with having been in the clinic and having had some experience with trying to evaluate patients and present them also with clinical trials and see what their interest would be and explain the trial, etc. So I think all of us have had that experience, and I think as Mark mentioned earlier, as we got started with the meeting, our goal is really to have a discussion with you today about, you're all experienced on the trial, so it's not really what do you think about the trial per se, but it really is, we know that how we as clinicians think about a study, and Karen brought this up very elegantly, is really important to how patients receive the option of the trial. And I've heard over and over from investigators that in patients where we think about Maestro, we also have to offer all the other options. So one of the questions I think we would like to understand better today as we have our discussions about patients is really, clearly we give options as clinicians because we don't even have a strong feeling perhaps that there is a best option clearly rising to the top. There are pluses and minuses with every treatment option that we talk about with patients. And so we're asking the patient to please help us weigh the plus and the minus of these options. So using the case studies, hopefully we'll have a chance to just get a better understanding of how you're thinking about these patients. So this first case, 52 years old. This is a patient who has 2 months of weight loss and abdominal pain. For 1 month, he's treated symptomatically, and then he develops jaundice. He has prior gastric bypass surgery 4 years ago and initially lost some weight, but now he's regained it. He has some sleep apnea and hypertension. He has been working as an engineer. His labs at presentation is a slight elevation of his bilirubin, AST, ALT, mild anemia. He's on these medications for respiratory status and hypertension. He has an endoscopy done with an EUS. A stent is placed, biopsies done in the region of the head of the pancreas, and the bilirubin comes down after placement of the stent. The biopsy of the lesion is consistent with pancreatic adenocarcinoma, and he's got a slightly elevated CA19-9. CT scan demonstrates liver lesions consistent with metastatic disease. So now he comes to you, and he's lost 13 kilos in 3 months, and his appetite now has gone away. He's eating, but still, and then because he's lost weight, he's not has as much appetite. And he has some pain now. It's prevented him from working just for 2 weeks, although he has gone to the office. But again, is this a symptom that is changing over time? So with this kind of case, maybe Sebastian, I can maybe start with you, of how this case, you're thinking now, first presentation to your clinic, what are you thinking in your mind in terms of
147 kilos, he's not small. Is this an American patient?
For me, I have to think about that.
Okay, so issues there. I mean, he's getting symptomatic quite quickly. He's lost quite a lot of weight. So he's steadily losing weight at the moment. He's got pain. So these are all, for me, active disease, symptomatic disease. Obviously you have to see the patient. Sorry, the bilirubin, that's all under control now, is it? He's had a stent, etc.
Yeah. Yes. Bilirubin is down at 1 point.
So that's all sorted. It's just the disease that we need to deal with. Well, the question is, what treatment options are considered? Was really, he's got systemic disease.
Yes, he does.
So it's palliative therapy. So what I would talk to him about.
So key question, 52, are you thinking, is there a particular regimen that you tend to base age on in terms of a preference?
No.
Versus 72? That's going to come up a lot.
Not necessarily, no, because you can get a 52-year-old who's very poorly with this disease as well. So it's not just a question of age. But yes, I've already got one in mind for this patient, which would be Gen nab-paclitaxel, because he doesn't strike me as being a PS 0 to 1, but I want to give him something as active as I could. He's a young man with 2 kids, and he's very symptomatic. As I said earlier, you know, I would say this chap would be PS2 really, by the sounds of it, 1 to 2 perhaps. He's been losing lots of weight, so I'd want to get on top. I'd want something with a response. I don't, you know, with every patient you talk through these things. One issue that actually I wrote down, you know, which will be relevant to this sort of setting is you need to talk through these toxicities as well with the patient, and that might be an avenue which would make this trial relevant, because gemcitabine as a single agent would be an acceptable regimen. But
That
for
would
me,
be something you would consider as well.
well, for me, if I was trying to be as active as possible, then I would probably.
So would you be thinking gemcitabine alone, or would you be thinking nab-paclitaxel option 1, nab-paclitaxel gemcitabine as a combo, option 2, or vice versa, clinical trial? Would you be thinking of in that
Option
context,
1, always
or would
clinical
you have
trial.
To be thinking of
Option 1 would be clinical trial,
Okay.
but having made the decision that you're going to recommend some chemotherapy, that's
Right.
decision number 1.
right.
And having made that decision, then it would be clinical trial, and then it's a question of which clinical trial and what you think would be most appropriate. I'd always seek to put someone into clinical trials, and I'd talk to them about them.
Yeah.
The other option outside clinical trial would be nab-paclitaxel.
Okay. So, Geraldine, may I ask your sense of how you think about a case like this? This is, again, since you have a variety of options that you could think about in the setting.
I think this is not a good patient for FOLFIRINOX because of the PS.
And is that the PS aspects are the weight loss or the pain or what?
Yes, I'm not sure. He's not able to walking, so yes, it is one. No, sorry about that. It's one. And how much is the bilirubin? Sorry.
1.3.
Ah, okay. It's okay. So no, we could consider this patient for FOLFIRINOX in France. And nab-paclitaxel would be an option 2. It's not so easy to discuss, and we would consider a clinical trial for that patient.
So any of those 3
Yes.
options. What would be the so you know pro versus con, pluses and minuses? What is the plus and minus?
He's a 50 years old with two children. Maybe in that kind of patient, I would be a little bit concerned to offer only gem, because in the clinical trial you have placebo. This is the only
Gem plus placebo.
Yes.
You mean Maestro, the
Yes,
trial design,
exactly,
gem plus placebo versus
Yes.
gem study group.
I would be a little bit concerned, but it's a discussion to have with the patient, because some of the patients are very keen to have the new drug.
So what if it were that? Does that come up when you discuss the clinical
Yes, sometimes
trial?
it comes. Yes.
50-50
Yes.
chance of
Yes.
gem plus something else.
It depends on patients. So I would offer the 3 possibilities to the patients. To the patient, sorry.
Okay. In your experience, you had mentioned earlier you used FOLFIRINOX without bolus. Is that correct?
Sorry?
FOLFIRINOX you're giving without bolus?
No, we tend to give bolus at the first time, but sometimes when the PS is not so good, we remove the bolus.
And is this a regimen you can continue each cycle with bolus each time, or must you change that dosing fairly early?
Some patients have the bolus every time. It depends.
Are able to tolerate that?
Yes.
Yeah. Okay. And Radmila, can I ask your experience a case like this? What would your group
I think we would decide
offer?
for gemcitabine and or for the clinical trial.
So not a
if one is
FOLFIRINOX.
open, no, not for the FOLFIRINOX.
In
And
your
especially, I'm really concerned about the loss of weight, and he would be sent to a consultant for nutrition. But on gemcitabine, we have a very good experience that the people get appetite again, and they feel good. so the quality of life is excellent.
So balancing quality of life with the treatment is important. I think you brought that up also earlier.
And if there is this clinical trial open with gemcitabine, then we encourage to take part in it.
Let me take the other point of view, just for discussion, and then we'll move to the next section. But this is a 52-year-old guy. He's having some symptoms. The discussion here has been mostly perhaps away from FOLFIRINOX, more toward combinations with gemcitabine. Other discussions we have had with investigators have brought up the point of view. It's a symptomatic gentleman, a little bit young. Perhaps I should be aggressive or very assertive with my therapy, and therefore try to improve his outcome by treating him with FOLFIRINOX as a combination. So what is the rebuttal or the discussion about that point of view? Could one get away with giving FOLFIRINOX in this patient and feel that you are not either over-treating, from a toxicity standpoint, that you are benefiting the patient?
You could try it. You could try it, but you're taking risks with him.
Yeah.
He's got disease in the pancreatic head and he's PS2. That's not the group that this trial demonstrated.
So as a clinician, your sense is that patients
you have to be aware of the limitations of what you're doing.
That you'll have limited improvement.
Yeah, what you're doing is palliative.
Therapy.
You're not going to save his life. You're going to try and prolong it.
Yep.
So there's a balance between trying to prolong it and trying to manage his symptoms and not putting him through hell in the meantime.
Yep.
And so on that risk-benefit equation, for me, nab-paclitaxel would outweigh FOLFIRINOX. Added to which you've got a longer tail of survival with a small group of patients who respond.
Karen, please.
Yeah, I don't have experience with, or not much with FOLFIRINOX, but if I would think about it, I wouldn't suggest it in him because of the fact that he has a pancreatic head tumor with a stent in place. The thing is, the man has lost 13 kilos, and like everybody says that he has this pain and weight loss issue because of his disease. I kind of expect him to have pain because he has a pancreatic cancer and he has weight loss, but he also had a gastric bypass before and he can have some steatorrhea. So I'm not that convinced that his symptoms are because of an aggressive nature of the disease.
Gastroenterologist.
So I'll always check for that. I'm going to ask him if he has diarrhea, if he hasn't, try and get him better that way before stating that
my concern would be his pain. He's got pain which is preventing him from working for 2 weeks. That's usually a bad sign.
Yeah, I know, but the weight loss is not
may not be
related as important as.
Well, you can institute Accrual. You don't need to wait on that. If he's going to have treatment, that's another thing. But if he is, I think you'd need to start it sooner rather than later because his performance status will continue to drop.
Yeah, but the thing is, like, as for other cancer diseases, it's like either tumor related or it's got something to do with his other medical conditions. And
are there things you could do to impact the weight loss and the pain to stabilize the performance status, perhaps, or maybe bump it from a 2 to a 1?
Start him on some treatment.
It's neoplastic
treatment.
therapy.
You could start him on Creon at the same time, things like that. But I think treatment for this sort of thing is...
Treatment.
Well,
of course.
If the patient wants it,
Sure.
Yeah, but the thing is, we're talking about whether we would recruit him for the trial or not. So I'm not going to say it's somebody that has a bad prognosis, that has rapidly evolving disease without thinking about other...
Yes, what other factors may be influencing the patient. Situation, perhaps what can be addressed clinically to improve or stabilize performance status. And Harvey, you had mentioned at your site many patients have had deteriorating performance status in a rapid period of time. Are these kinds of interventions something that your clinicians and that in your clinic that perhaps can be addressed to keep some of those patients stable for a period of time, perhaps?
Possibly. I mean, I think they're always trying to treat them fairly aggressively, really, if that's an appropriate thing to do.
Yeah.
So, this is a young man, isn't it? So you keen to improve things for him, but, as much as possible, really.
Yeah, yeah.
I mean, sorry, I missed some of the conversation, but I mean, with this, that our view would slightly changed since Paris now because of Siege trial and that rehearsal. I think in terms of performance status, probably what we'd do, because you want to get on with this very quickly.
So make a treatment decision.
Yeah,
quickly.
Well, what we would do probably is we'd see him on a Wednesday, put him on steroids and crayon with lansoprazole or whatever.
So trying to stabilize weight,
just to see, and painkillers and everything.
Yeah.
We probably, because I mean, clearly, although he's lost weight, I think he's still PS1. I wouldn't call him PS2 yet. I mean, he's tried to get to work at least. He's not like lying there. So what I would do is I would give him all options, actually, and then I would see him the following week. And if his performance status is improved to 0-1, then I would be potentially giving him fulvestrant. If it's still PS2 or worse, then absolutely I'm not going to give him fulvestrant. I don't think we would give him fulvestrant.
So if it's
but in terms of our trialist hat on, I agree, we would definitely give him chemotherapy. So then the debate is, would you put him on Siege? Because, why give him Gem/Nab-Paclitaxel off of trial if you can get it on a trial? So be a real trialist and say Siege, and that he would go for it because we'd be comfortable. They all get the drugs anyway. If he didn't want those toxicities, he still wanted to trial, we also offer them Maestro. Absolutely.
So the toxicity, then for you, the difference is what's the toxicity profile of TH302 plus GEM versus NAB-Paclitaxel?
Well, actually, then I would say that then it's informed choice. Then it's actually informed choice of what the patient wants to go through. It's not what I want him to. I can say I'm comfortable. There's 2 trials. Then actually, I would be more comfortable giving the patient the choice because I actually remember.
But I guess what I'm asking, how would you distinguish for the patient? The patient doesn't know. I'm here to ask you, doctor, to tell me what am I supposed to do. You as the doctor, and this is just a discussion again, are telling the patient you have 2 clinical trial options. How do you distinguish those clinical trials for the patient? Is it on the basis of side effects, drug schedule? What is the distinguishing factor between those 2 options? So how would you pick a patient for one versus the other?
Well, that's interesting, isn't it? I mean, so when you get all these options, you say, remember, there's an inoperable disease, you're palliating them. You say, look, if it's a 1 drug plus or minus a novel drug, it's 2 drugs versus 3 drugs. The payoff or the disadvantage is toxicity, right? So you've got to say to him, look, the active regimen, the most active regimen is 3 drugs, but the payoff, the downside is very toxic. 2 drugs, less toxic. 1 drug plus or minus novel agent, least toxic with possibly a very interesting novel agent. I mean, you can talk about all these. I remember seeing a guy who had a potentially operable head of pancreas cancer. The surgeon went in, saw a tiny liver nodule on the outside, took it out, metastatic pancreas cancer, just on the basis of that. And I thought, he's actually pretty good. We could have given him anything. His view was, I've been told metastatic pancreas is terrible. And what he did, he went to Heidelberg and had, chemoembolization and some crazy stuff, right? So, I don't know what this. I mean, it's all a bit soft, isn't it, discussion? But what does this guy want? And actually, it's very much patient choice. And I think we just put the trialist hat on and said we would offer trial. I don't have a problem giving him Maestro trial, but he's just got to be aware of that. That's actually what he wanted. Like, he wanted GEM because he wants to just get on with his life and with very few toxicities. And I'm comfortable with that. It's all about informed choices.
Right, of course. Yeah.
I don't really have any.
And again, that's the discussion, and we'll move to the next section. But really, with this opening case, is what factors do we think about as clinicians when we're trying to offer patients options? We say, as clinicians, we would like our patients to be well informed and to have all the options offered so they can make and be comfortable with their decision as they move forward with treatment. But again, we influence a lot of how patients think about treatments with obviously the types of data we present them, whether we mean to or not. Whether if we think a clinical trial is important, we will emphasize that perhaps differently than for another patient where we think maybe they're not a great candidate for a clinical trial. We offer it as an option, but maybe it's emphasized or presented in a different way. So we have a lot of, obviously, different approaches for patients in the room based on your site and what you have to offer the patient. But again, this case just, I think, has been interesting to discuss, again, aspects of where do you position these different treatments. He's a young patient, but not young, not 40s or something. So again, he's got a few symptoms, a few medical problems, maybe not the prime candidate for FOLFIRINOX based on what we've heard or read about the regimen and the issue with stents and some complications there. How do we judge performance status? Obviously quite variable from clinician to clinician. I heard PS2, I heard there are things here that are potentially addressable from a performance status standpoint, that maybe he could be stabilized, or that would make his performance status a little different. And then treatment options across the board, nab-paclitaxel, SIEGE trial, Maestro, single agent gemcitabine. So I think the discussion just on this first case has been quite interesting to just hear how one might approach the cases.
Just, because you said, what about the patient who just says, "Tell me, doctor, what would you do if it was me?"
Because don't they say
and
that?
No. But then he said, "I'm willing to take toxicity." Okay.
Of course.
I would actually, and I hate to say this because we're on a Maestro trial, I would say to him, go on to the SIEGE trial because you're PS1-2, you get active drug, and you're prepared to hit toxicity. And remember, because we can get FOLFIRINOX as second line at any point, I would say you get a good trial with 2 active regimens. You do well, fantastic, great. If you don't do well, you weren't going to do well.
And what I'm hearing a little bit is you would offer SIEGE because the patient gets 2 drugs regardless of either
Well, one, he gets a trial.
Well, I understood.
And 2, he gets 2 drugs versus single agent gem. If he says, "I'm willing to take toxicity," and we're not sure whether we're giving FOLFIRINOX.
Because I would assume you would give second line FOLFIRINOX if the patient progressed off Maestro, for instance.
Yeah, no, we could, but he's saying, "I'm willing." I actually don't think gem TH302 is a very toxic regimen. I mean, we've only got one person in it. She's I can tell you about it, but I mean, she's a fairly elderly, fit person who's had no tox. Whether she's on active drug, we don't know. But, it's not toxic, it's locally advanced disease. We can talk about the profiles of what kind of people we bring in. We're comfortable with that. This guy doesn't have locally advanced disease. He's got liver mets, even if they're small, and he's not very well. So if he tells me, I don't know what Sebastian would say, I would say SIEGE. I'll go SIEGE, and, because on a trial you're being scanned more frequently,
But you're scanned on Maestro too. I'm not trying to...
I know that.
Just, what's the distinction between nab-paclitaxel that some of you can choose, gemcitabine, that combination, on trial, off trial? Understood, trial is your first priority.
But the comparator arm for SEED is still a doublet.
Correct. That's one aspect that I'm hearing is my patient will get a doublet regardless of which arm.
That's right.
Which may be why you might say I would.
And provided he comes to me and says, "I'm willing to take some toxicity," and if you're not, then I'm very happily doing.
Can we clarify?
Yeah.
PS.
I don't know, can we?
Yeah, it's fairly simple, isn't it? Minor symptoms, PS1 is minor symptoms not inhibiting activities of daily living. PS2 is resting up for less than 50% of the day. This is not PS1. This guy
he's not going to work.
Yeah, this guy couldn't go on to Maestro.
But this doesn't
because this is not minor symptoms. These are impinging on his activities of daily living.
What if I treat them? He's not
but he wouldn't go on. He couldn't go on to the trial. He couldn't go on to Maestro because he's not PS1.
Well, I disagree with that
He's
because you have to, this is not enough information.
You're saying he's PS2.
Yeah.
Going to the office is he's working.
He's got pain which has prevented him from working for 2 weeks.
There's retirees who never work and are still pottering at home, showering themselves, bathing themselves. Activity of daily living does not mean work. It means that you can look after yourself. He may well be able to bathe.
But it's minor symptoms, not causing any impingement. I wouldn't say these were minor. I wouldn't say this was a PS1.
No, but as I said, we would give him 1 week to see whether he's improved. If he doesn't, he's not on Maestro.
What's your sense, or do you have experience with grading performance status?
I think with work ethics, people who function, it's not about the drive to work, about getting yourself out of bed and going to work. I mean, people try to go to work, I believe. So if I would say his performance has too, because...
You feel that with this description, so anyone else feel he's PS2?
Sebastian, but if you're not considering him fit for the trial, would you suggest that paclitaxel or fulfirinox, because it's very
Paclitaxel,
in my
I've seen the
opinion
subset
it's very
analysis.
difficult.
Well, I've seen a subset analysis for impact demonstrated a greater survival advantage for the PS2 group than it did for the PS0-1 group, actually. So there's data suggesting that PS2 does well with gem-nab-paclitaxel.
But can they handle all those neuropathy?
Well, one of the issues is, well, the neuropathy is reversible, obviously, with nab-paclitaxel as opposed to with oxali. And one of the issues is he's got pain. You need a response to relieve those symptoms. So, one is, for me, he's not eligible for the trial for Maestro because I don't believe the PS is 1. 2, if you're going to treat him, and I suggest there's a real question about, you know, have to have an honest conversation with all of your patients about that. But if you're going to treat him with chemotherapy, he's fit enough for systemic treatment, and I would say that fulfirinox would be difficult to justify for this patient. You could try it, but it'd be difficult to justify. So it leaves you a logical option to go for that combination.
So, one last question.
No, hang on. I'll just check that before I say that. But you're
Actually,
the C trial our performance data too?
I think it does.
Yeah, we're not sure. C
I
trial.
think it does.
It's new. Raise your hand if you've got the C trial open.
No,
It's just
UK.
It's really just
Just
the
the
UK.
UK trial.
Yeah, it's just UK. Okay, so that's it's not everywhere.
But the general discussion really is the selection, in my mind, the question was really nab-paclitaxel gemcitabine is a combination, which essentially that's siege, whether schedule or whatever. But basically a doublet of those two drugs versus something else. And what are the two
because I think single agent gemcitabine for a man like that is really justifiable. So I wouldn't have a problem with sticking him into Maestro because he's, you know, I don't have a problem with gemcitabine, but I can't see that he fits the PS0-1 criteria.
Okay.
But I think, again, performance status, we know, is a very subjective thing. So you have to see the patient and talk to them. Clearly on paper,
Is anybody doing here a second opinion on the PS of patients?
Well, don't you have, for the trial, you have to have 2 people, don't you?
The first person has to say the patient is a performance status 0 or 1 for the second person to even have a chance at making an assessment, right? So, So, thanks. That's a very interesting discussion to start. And then now let's have some.
Sorry.
And this is just so we're all on the same page of again data and backgrounds. Thank you so much.
Which is the laser point.
I think he's going to use the. Do you want to mic him?
So I've got to thank Mark and Laura for inviting me to do this presentation. I must have been really quite vocal and has been.
You got the sticker, man. You got the sticker. That was it.
Oh, sorry. I usually talk loud enough.
Oh, so the mics are, we are going to summarize comments. So the mics are not for, you know, nothing will be public. It's just so we can capture everyone's comments.
It is a small enough room, and I've got like a head cold, but I'm just, hopefully everybody's hearing everybody, but if not, we can mic it a little.
So I'm a medical oncologist. I finished all my standard training. I'm actually doing a trials fellowship with Focus Horse, is actually a metastatic colorectal trial at the MRC Clinical Trials Unit. But I also work as a senior fellow with Dr. Bridgewater and Professor Hockhauser at UCLH. So that's my focus for it. It's got nothing to do with pancreatic cancer. So I'm going to try and whip through a lot of these slides. I mean, this data is out there already. I think, as Nora and Mark want me to do, it's an open conversation, and I can always say what I think, but actually it's more important than what you guys think and what we're going to do. Because I think it is very exciting in some ways that at least we do have options as clinicians, and patients have options to decide on kind of their own kind of lifestyle cost, risk, benefits of what they want to do. So we all know it's bad. Pancreatic cancer is bad. Lots of new cases, most of them never operable, therefore never curable, and there's lots of data out there. I'm going to skip right through that. But this is the problem. So we have, if you take about 100 patients, and we all seem to have approximately 20 per physician or 100 patients in our centres, I think this is about right. Up front, the surgeons will jump on these people. I mean, they'll take too much trying to work out whether it's operable, but they will carry on jumping on them and try and resect them up front, and I think that's great, but that's a very small percentage. Then you have those
clearly metastatic patients. I think there is this interesting now, the local advance. I mean, I think this is where FOLFIRINOX and even gemcitabine is going to change management. We've got SPAC5, which is a terrible trial actually, but in some ways because I think it's not greatly designed. But you know, people are really thinking about neoadjuvant therapies for the locally advanced. The surgeons are jumping up and down because I don't know if for Sebastian it depends how aggressive your surgeon is, but you know, they will now say give them the juice, give them the FOLFIRINOX. We have had R0 resections for this, and they like it more than chemo-rad because you know, chemo-rad not great. So this is the guidelines from 2012, and they probably need to be updated a bit. Things are moving fast, and that's good. So stage 4. So stage 4 being metastatic cancer, not locally. First line, gem, FOLFIRINOX now because of Accrual 11. Gem-elotinib, I'm slightly surprised. We'll look at the data. I mean, I think gem-elotinib is the kind of trial that no one ever wants to do again. And a lot of people actually use gem-cap, and I'm interested from everyone, you know, a lot of people use, right, we don't at UCH, but at the Royal Free, and I know at the Marsden they use a lot of gem-cap. So does anyone use gem-cap instead of gem? Particularly in Karen? Yeah, okay. Of course now there's this nab-paclitaxel gem combination, and then of course always think about a clinical trial. In second line, FOLFOX, gem, maybe FOLFIRINOX. We've had a few who were, we had local advanced disease, gave gem, then scallop type radiotherapy, still fit, and then progressed, and we were happily giving them FOLFIRINOX for metastatic disease. So you can catch them in second line for FOLFIRINOX if you select them carefully. Okay, so this is interesting, the unresectable locally advanced pancreatic cancer. So it's interesting. So we can give chemotherapy, and we've been talking a little bit about maybe even though Accrual 11 did not allow locally advanced people into their criteria, we are now doing it, and I understand there's a lot of FOLFIRINOX, not in terms of giving a novel agent on top of FOLFIRINOX, but the scheduling of FOLFIRINOX around, you know, preoperative or adjuvant FOLFIRINOX. So here we go, chemotherapy, it could be gem, it could be FOLFIRINOX, chemoradiation, or chemotherapy following chemoradiation. And it'd be interesting, I mean, we can stop here. I mean, for locally advanced disease, how many would give chemo-rad upfront, just upfront, without any induction chemo?
We do it with gemcitabine and radiation. Certainly if there's a pain issue involved, this is a quite common thing to start, yes.
Okay. And does anyone use, like, liposuction or scallop, the kind of giving a period of chemotherapy and then chemoradiotherapy?
I use that a bit. Usually I try and get 6 months of chemo in to start with if I can. But after 6 months, patients get quite worn out.
Yeah.
And you can try and bring things to a halt with a block of chemoradiation at that point sometimes.
Sure, okay. And do you use CAP or do you use GEM as your CAP? Okay, good. Wow. And then, of course, again, a clinical trial. So, of course, Maestro will allow this. That's good. So, the changing landscape. So, here we've got the original Barris trial, which we'll show that in a second. Gemcitabine versus 5FU versus best supportive care in 1997. Taken lots of, I would say, essentially negative trials in terms of at least overall survival benefit, using GEM as the backbone, and really nothing worked. And I really wouldn't call this a positive trial. I'm going to be biased here. I don't think this is a good trial. And then suddenly we have a really, I think, a step change in management. So of course, FOLFIRINOX had very tight inclusion criteria, very few heads because of the bilirubin issue. But you know, it was very active. You know, it's not the laser pointer between two lines; it's a proper gap. And we'll see that in a second. And now, of course, we've got MPACT, where we've got another option for patients. So now paclitaxel GEM versus GEM. I think the other thing is interesting. I don't know we will see it, but the GEM control in all these has changed slightly. I mean, we'll just have a look. I think maybe we're selecting patients better, but the people on GEM in most of these trials are actually doing quite well. So, so this was the original pivotal trial, and I think the only thing I'm going to say about this is that we never use this anymore. It's interesting, and we alluded to this, that, you know, assessing clinical benefit rate, we don't use that as an endpoint at any point now. When have we ever used it since? Maybe in lung cancer we used to do it, right? But now lung cancer is very exciting. We don't use clinical benefit rate. But on the basis of that, really, that's how they said GEM was better than 5FU. Okay, so I'm not really going to say very much about this. I mean, I think the only thing I would just say is that just look at this month, 5.65 months on GEM alone. Okay? Any questions about that? Standard data. Okay, so this is the GEM allotinib study. So they had kind of disease control rate here versus GEM, but actually, you know, actually look at the overall survival, it's not significant, okay? Again, just look at the GEM, 6.24 months, so maybe a month better, okay? And I don't know many people who use gemcitabine because the LAPO7 study did use gemcitabine, and in fact they did worse. You know, they had gemcitabine, then they had CAP, so they had CAP with their radiotherapy, and they did worse. We don't know exactly why. Some bad biology there. Okay, then we move really, I think, where it's just kind of changed the landscape, and this is where we start thinking about what can or should we do for our very fit patients. This is the Accrual study. Remember, they were definitely stage 4. I looked back at this data, and a lot of them had resected primaries. So we talk about all the tails, and they didn't have heads, but actually a lot of them had no primary in them. So they must have had their resection a while back, and now they've got metastatic disease. And I think that is a different type of patient to someone who's got local, you know, their primary in situ. They are not well. They've got pain issues. They're always going to have problems with blocking the stents, or problems even with tail pancreas cancers. No prior therapy, chemotherapy, very good performance status, age less than 76, and of course the bilirubin issue. And this was an interesting study because remember they started at the phase 2 and they first looked for a response rate, and they saw the stunning response rate and then pushed that on to an overall survival benefit, which is the right type of trial, you know, unlike FIRE 3. If you ever do colorectal cancer, never use overall response rate as a primary endpoint in a phase 3. So the overall response was stunning, 32 versus 9. That's got surgeons really happy if you're talking about local advanced disease. But remember, here we go, neutropenic rate 46%. You were allowed GCSF, remember, after you've had one event. And of course we are now changing what we're doing in terms of giving upfront GCSF, maybe if we're giving it, or maybe less. But this is stunning. I mean, this is what, 6.8 versus 11.1 months. And that is significant. And I think that's interesting about, okay, we're not curing these people, but that's almost doubling your overall survival. Okay. And you have potentially second-line therapy if you're fit enough. So here's the impact, and I think this was really good. It's nice that they included the PS2s, and as Sebastian alluded, it looks like the symptomatic PS2s actually, in subgroup analysis, did better. I actually, and in fact, talking to at this pancreas study with the Americans, you know, the neutropenia rate is still significant. You know, 38%. It's pretty significant. 46 versus 38. I think that's about the same. I do think the neuropathy is a different type of neuropathy. And I think that is significant for the patients if you explain to them that. But this is a significant trial. Okay, so overall survival benefit. I'm just trying to see clearly 14.8 versus 11.1. So that's stunning in the sense of the GEM. I mean, that's the GEM survival. I think is quite impressive. Am I reading this right?
8.7 versus 6.7.
No, the 70th percentile. Sorry, yes.
8.7.
So that's still better. So it's going up slightly. 5.5 for Boris to 6.1 with GEMCAP to 6.5. It's kind of going up. So good patient selection, perhaps. Okay. So frontline. So here we go. Let's bring them all together. I think the significant things are here. So here's your regulatory GEM trial. Okay. PFS 1.3. Nothing more. Not a lot. Overall survival, though, interestingly, that you've got an overall survival 2.1, 4.3, nothing, and a little bit. And I think, you know, these are good. Well, I'm really going to say I don't think it's a good trial, but most of them are very good trials, and you know the response rates are very good. And here's the kind of tricky bit. You know, here we're talking about Accrual 11 versus impact, the response rate of 32 versus 23, and we have certainly at UCH a debate of really, if you want aggressive chemo, you know, disease, when would you ever give nab-paclitaxel over FOLFIRINOX for response rate. The only thing for us in a good performance aid patient would be the patient's choice. If the patient says, I don't want a line, I don't want 3 drugs, blah, 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 of course we would actually offer them a Rapid. But other than that, in terms of survival and response rate, we would always try and give them FOLFIRINOX if they're willing to take the toxicity. Okay, so here's the toxicity again, just all back to back. GEM pivotal 26%, 46-38, diarrhea, pretty manageable. I think that if you are also treating colorectal cancer, because we are very comfortable, if you have done trials like the Olivia trial where we gave FOLFIRINOX, we've now got the Bacchus trial giving FOLFIRINOX. So, you know, we are happy giving that, and we're happy putting lines in people's reports. This is not, from our point of view, a difficult thing to deliver, though we know biologically our pancreas patients are not the same as our kind of good performance colorectal patients. Okay, dosing and schedule. Okay, so impact, you know, so here we go. You've got, you know, weekly GEM with paclitaxel. You've got 2 weekly FOLFIRINOX, and you know, we're talking about the dose intensity. The most important thing, at least from the Accrual 11, was overall they worked out everyone only median was 10 cycles out of 12, and overall dose intensity was 80%. So that's why people have adjusted it and said, well, actually, if that's the case, it's better to give them upfront 80% all the way through for 12 cycles, and we get pretty good results. No one has dared, and this would be a good trial, would be dose-reduced FOLFIRINOX for 0 to 2 versus nab-paclitaxel GEM, and I don't think it's ever going to happen. Okay, I don't think anyone's going to go up against FOLFIRINOX yet, because I think it'll be hard as a registration trial against anything else. I'm interested about, and I'm just going to talk about cost, Karen. You said in Belgium you have to pay for your own oxaliplatin or irinotecan. Is that right?
No.
Or it's not reimbursed?
So we are given it a medical need, the FOLFIRINOX. It's not available, not reimbursed, but we can easily have it from the companies as we treat so many colonic carcinomas. But the net back, they have to pay it out of their own pocket, yes.
It was interesting. So when we put FOLFIRINOX onto our drug committee at UCLH, we went straight down the line on the Accrual 11 kind of guidelines of 0 to 1, everything. But when it came to cost, at that time FOLFIRINOX was not was quite expensive still, and then of course oxalipatins come off patent. And we worked out that everything is drug ring fence in terms of time on unit versus, you know, giving the. Actually, it's as cheap to give FOLFIRINOX 2 weekly than actually a cycle of day 1, 8-15 GEM in terms of time for the patient, employing chemo nurse to give it 3 times out of 4. And the only cost which we couldn't work out was the cost of putting a line in someone. Okay, but in terms of drug cost and time, FOLFIRINOX actually came out cheaper than giving weekly GEM.
Except for the admissions for neutropenic sepsis.
Okay, so when we audited this, and actually we had about 65 patients on FOLFIRINOX, and we had 2 admissions with neutropenic sepsis. I thought that was pretty good. I mean, what we did was we did dose reduce people up front, which we were worried about it. We didn't give GCS up front on first cycle because that was in our guidelines. But I would say that's not too bad. 2 admissions with grade 3 neutropenic sepsis is not bad. Neutropenic fevers happened, but we managed them as an outpatient. So again, how do you manage a neutropenic fever? That's a different discussion. Okay, so I think this is really interesting because this is where, you know, in some ways Maestro trial is great, but we want more second line trials. What's the evidence of giving any kind of treatment in second line? So here we go, all very small studies. First line regimen was GEM, FOLFIRINOX retrospective. I mean, okay, I think these are okay. I mean, what we know from the Accrual 11, they did do a little bit of like what happened to the patients who progressed, and what we definitely saw was the people who had GEM first line, very few of them got FOLFIRINOX. They got GEMOX, they got FOLFOX, they got a bit of IVU, whereas the people who had FOLFIRINOX were actually fitted enough for not only GEM, but again, GEMOX. And I think that's interesting in itself. And we might feel very comfortable about saying Maestro first line, and hopefully you improve to the extent that you might be able to have FOLFIRINOX in second line. I think there's a discussion to be had about how comfortable we're saying that FOLFIRINOX in the registration trial is first line. You know, we're talking that we can give FOLFIRINOX second line, but where's the data? You know, where's the data of really survival, progression-free survival? I don't know. We don't have it from here yet. I think that's it. Right. I didn't know. Have I covered most bases? Is there anything else?
I think so. Anyone have comments to add or your experience?
Just one comment.
Yeah.
Do you often give FOLFIRINOX in second line? Because most of the time patients are tired and...
Yeah, no, we don't. I mean, to be honest, we only started using FOLFIRINOX about 18 months ago. And as I said, it's a very small population where we would do it in second line. And I think the population we do it is if they've either got locally advanced disease from the start and they had GEM and then chemo-rad, and then because we follow them quite quickly, we do, you know, scan them every 8 weeks. And so we pick up the kind of minor progression and get in there quite quickly before they deteriorate. The second thing is actually a trial as well. So if we put them in a trial, forget whether it's chemo, whether it's locally advanced, if they're in a trial, they're already being very heavily monitored, you know, every 8 weeks or whatever. Whereas we normally give three monthly scans, you know, 6 cycles of FOLFIRINOX or 6 months of GEM or 3 months of GEM. So you might be able to pick them up just before they go. But this would be the really young patients. You're not going to do it in your 70-year-old on second line. You would do it in your 40 or 50-year-old, I think. I mean, so it is a completely different population.
Yes, exactly.
Your experience, has that been something that you've utilized?
Because we give most of the time FOLFIRINOX in first line. We don't give it in second line. Maybe that's fine, but most of the time patients in second line are more tired and...
Right.
Yes.
So I guess that's one question is in considering, and part of the discussion of, you know, can we implement second line therapies, is really what is the quality of life of our patients at that point, right? If they've been on a first line treatment and now perhaps are progressing, can we offer them second line? And, you know, Karen, you brought up several points earlier of that is one aspect of consideration, I think, in terms of, you know, in what solid tumors have we seen combination chemotherapies really improve survival versus sequential agents that perhaps are better tolerated and perhaps still in sequence offer you perhaps a more prolonged survival. Have you had pretty good, I don't know what your experience is in these sequential therapies in the pancreas cancer setting? In your,
what we do, so can't compare it to
any of these single...
Can't compare it to the trials, but there have been publications on single center experiences. There's one from Julien Taillep as well, changing FOLFOX to cis5 GEM, something like that, where he has better overall survivals, which I have as well.
You are talking about FIOGEM?
He has this FOLFOX GEM or GEM FOLFOX. He has something like that.
Okay.
And he has a median overall survival like 11 or 12 months, what is cited with the FOLFIRINOX trial. And it's my experience as well, but like we get younger. I mean, we don't get the old patients that much. We get a specific subset of patients. So it probably influences our results, but I'm kind of happy giving them one treatment after the other. Maybe we should do a Cairo kind of trial.
Well, exactly. I mean, I think that what we're trying to move on to is how we now treat our metastatic colorectal patients. You know, you've got to think about what's the intention. You know, if you've got potentially resectable liver mets and you give them everything, if you've got potentially resectable local advanced disease, you know, you've got the patients, again, these are kind of N=1 that investigates best story, but you know, they've got the people who have got a mental mets and they get a surgeon to resect everything, you know, and then they come back 6 months later disease free. We don't know how to select the patients. We don't know how to select the patients, but the fact that you can get such, I think what the amazing thing I've seen is that you get such a dramatic response to FOLFIRINOX. Despite the toxicity, I have never seen that with GEM. I've never seen such dramatic shrinkage of disease, and that's exciting. I think that is exciting. But I agree, if you've got inoperable metastatic disease, you've got to be really careful about what you're telling your patients before FOLFIRINOX. And that's why I'm comfortable giving Maestro at that
treatment
point.
Is. Sebastian, you had a comment.
No, I was just interested because more and more you select. I mean, it's case selection as well, isn't it? But you know, you were just alluding to metastasectomies, etc. And how frequently do you let your surgeons operate on patients with metastatic disease?
I know, so you don't, but so there's always the n=1, which is
There's
that,
always
you know,
a
and then you
surgeon
I'm not saying they
somewhere
go
who-
straight into surgery, but you know, they you know, say well, the surgeon will say, well, just wait 3 months or 6 months, and nothing happens to the liver.
No, we do it very
Yeah, and you
occasionally.
just do it. I
Very
mean,
occasionally.
I'm just saying that at least you even have that option. I mean, you would never do that in the pre-era of gemcitabine or things. So I'm just saying, it's good for our patients. And I think there's those opportunities for Chiro-3, like, you know, treatment break strategies, maintenance therapies after induction for FOLFIRINOX. I don't know, but I think it's great. I think it's good.
Well, and I think you're going to see these data sets grow in the publications. I mean, these are small N numbers, but you're just at the forefront. Plus other novel agents that are kind of making their way up in the second line setting. Pancreatic cancer has always been a disease where frontline therapy, everybody started there because the overall survival is so dismal. Now you're starting to see some progression where you'll see second line drugs. So I think of Insight, Merrimack, I think of Halozyme. They're all looking at second line trials, right? Where they never looked at second line trials.
So think about lung cancer. I mean, lung cancer is all in second line now, isn't it?
It
It's
is,
got
yeah.
good first line and novel, you know, biologicals, and second line is interesting.
Even TH302, their 440 patient second line trial. It's a second line trial with pemetrexed, right? And they're moving it up. So, yeah, good discussion.
Great.
Sure, I was slightly surprised, talk about dismal prognosis, with your first slide, when you said that among the resectables, 20% is still alive at 5 years, and I want to share this surprise with others here on the table. Were they all operated by neoptolemus? Because 20% seems quite a bit. I've seen many pancreatic cancers. I think there's always a palliative surgery, and 20% is quite high in...
This is not
It's
my
a
data.
general statistic.
It's not my
Yeah,
data,
yeah,
and
yeah.
it's not
We just asked him to comment on the
Professor
data.
Malago, I mean, he did work some over. He's one of the most
those are
aggressive
the results of
surgeons
SPAC,
ever.
aren't
I
they?
mean, you know.
So those are
Is
the
that your
SPAC.
experience, that 20% is alive after Whipple?
5 years, I haven't ordered.
Well, we don't see them because they get we never see them.
I mean, that's a
Mr.
multi-centre
Whipple.
European trial. The SPAC came up with that, didn't it? So
Perhaps were amphilomas or neuroendocrine tumors, but...
no, those were all adenos.
All adenos, yeah.
All operable adenos going straight to surgery. I'd like to do something before the surgeons get hold of them personally.
Yeah, I mean, I think
You have to do that in August.
Yeah.
When they're all on
that's
vacation.
right.
Yeah, that's right. Just sneaking out.
Yeah.
You got your 1 month. That's it.
Yeah. That's right.
Great. Okay.
Great. Yeah. Aki, thanks so much.
Very good.
Great. So let's go on to another, using that background and again the information experience you all have, to our next study. And in this case now, a 65-year-old patient. He lives a distance away from you, 80 kilometers, presents with some weight loss, about 15 kilos. This case was presented at one of our previous conferences by a colleague in Frankfurt. So he arrives in their city for workup of his pancreas mass. So they're a referral center and the patient came to them. Presented to the ER with acute gastrointestinal bleeding and hypovolemic shock. Hemoglobin was below 8. Had an upper GI endoscopy. There was identification of the source of bleeding, but they couldn't treat it through the endoscope. And a CT scan also was done, and he has inhomogeneous pancreatic mass in the head of the pancreas, multiple liver mets. He has a surgical laparotomy with the bleeding ulcer, and source of bleeding is controlled surgically, and a liver biopsy is taken at the same time, and he has metastatic adeno-CA of pancreatic origin. About a week after, his bilirubin is 10, and now he has an ERCP done with a stent placed, and by the time he is sort of better post-op and his bilirubin has resolved, it's about a month since his presentation at the location. His ECOG at this point is assessed as 1. So there, it's given. No discussion
We're giving it to you.
there.
It's
We're
not-
just telling you. Yeah.
Not for discussion.
Not up for
Sebastian's not in the room, he's going to miss that.
We'll go back to that.
When he comes back in, we're going to say, this is a performance status 1, Sebastian. This is it.
Yeah.
Watch out, when you walk out of the room, we talk about you. Sebastian just walked in. He's a 1. He's a 1. This is a 1. Just want you to know.
No question. So, Francois, may I ask your opinion on this case and how this case is discussed or considered at your location?
Well, in my location, this is, well, we don't have the variety of possibilities that you all have here in the UK are here. So this is, I know he's 65 years old, but is that too old? And you say that he has a PS of when? So that shouldn't be too difficult for us to choose to enroll this in a trial. Gemcitabine should certainly be something we would offer now, and with the trial is just something on top of it.
So it's a pretty straightforward decision
sure.
at your
in
location.
the environment where we live and the possibilities we have. Yes.
Yeah. Radmila, any comments on a case like this at your location? And
Well, the age, I would need to see the person.
Okay.
Because I think there is a difference between the shape of the person and the age.
So 65 years old, you may consider, you would want to see the patient because the performance status may be better than you think, or less?
Of less, yeah.
Less. So you're thinking maybe the patient's not as good a condition as you think. Okay.
And I think if he is better, or if he is okay, then he is certainly a candidate for chemotherapy, or for gemcitabine.
Would you ever then consider this a FOLFIRINOX candidate? Let's say he's ECOG 1 minus, not a 0, but he's, a few symptoms, but not really significant. Is this a patient, since you have access to FOLFIRINOX first line, is this a patient that your group would think of FOLFIRINOX, or not really? Not
no,
really.
I don't think so.
Because of age, or it's not?
It's the age and also the history and all the complications.
Too many medical problems going on? I think so. Okay, all right. So again, gemcitabine monotherapy or clinical trial or possibility?
Clinical trial possibility.
Okay, all right. And Geraldine, your location, how do you?
On the paper, it can receive FOLFIRINOX, but it's unusual story he has. So, no, it's not very common to have this kind of story at the diagnosis of a metastatic pancreatic cancer. So,
so you're leaning away from FOLFIRINOX first line for this case?
I don't know. It took 3 weeks to recover.
Yeah.
He had a surgery not so far away, so there is a risk of neutropenia. So I'm not sure I will offer the possibility of FOLFIRINOX, but it's up to me because on the paper you can.
Yeah. So on paper he meets criteria where you might still consider it. Does the stent, how do you manage stents, or your colleagues, the stent experience of patients on FOLFIRINOX with biliary stents? There have been lots of...
We are... sorry. We have oncology, GI oncology department, and just next to it, the GI department. So they perform ERCP, sorry.
No, that's good. Yeah.
It's not in a good order for me. Very easily, and it's working very well. So sometimes it's not working, but most of the time we have a very good experience, and most of the time we have the diagnosis, the result of the biopsy, the bilirubin is okay for treatment.
And you are comfortable with potential risk of cholangitis on...
I don't see so much...
has not been something you've seen?
Sepsis, if you have sepsis, it's because the stent is not working properly at the beginning. There is an issue. Yeah. But most of the time the stent is working. Yeah. You don't have... it's not... We have patients under FOLFIRINOX with a stent. It's not a contraindication.
Okay, not an absolute contraindication. So Sebastian, performance status 1 patient.
I think this is a really good maestro. This one is.
Yeah, really.
This one is.
So why not siege for this patient
gemcitabine
at your location?
For me, he's not, I know it's classified as performance status 1, but he's got a complex history with bleeding. He's got potential risk with neutropenia. We've just seen what the risk of the Gempac and Taxol is. He's that much older. We want to get him on some therapy quickly because he's actively bleeding and he's symptomatic, and I find that can be quite helpful as well. In those circumstances, gemcitabine as a single agent is entirely acceptable for a patient like this. In fact, it's possibly optimal.
More optimal than a combination?
Who knows? But I think that I'd be really comfortable putting him onto the Maestro.
A patient like this. Yeah. So let me flip it the other way. Why not nab-paclitaxel?
Yeah, because it's like we talked about at the beginning, the differentiation between FOLFIRINOX and gem-nab-paclitaxel. It's that blurring of the lines and being able to define precisely which patient is more suitable for which, and it's that balance between toxicities and benefits. This chap's really quite sick with his locally advanced, invasive into the duodenum or wherever, I don't know what I said, but it sounded like he almost needed a bypass actually reading that, but and he's PS1 but only just. I don't know what it is. I'm just struggling to define what makes me think that this is a gemcitabine patient.
It's hard to define, isn't it? Verbally, it's kind of hard to.
But yeah, the constellation of these symptoms and this presentation makes me think that he's just been admitted with hypovolemic shock, that sort of thing.
A month ago.
Yeah.
Yeah.
Okay, and now he's normalised.
Yeah.
Did he live 80 kilometres away from the hospital?
So that's another question. He lives a distance. So I don't know how does that work.
Any therapy.
You're all referral centres, so how does that work for when you have patients on trials?
Well, any therapy has, you'd have to consider that, wouldn't you? What's available and what they want to get. So that where they live is fundamental. Certainly for some of the trials that we run, it's a big issue. In terms of comparison to standard therapy that you deliver, it's not a vast difference necessarily.
Right, so they still need to travel to you,
right, still going to need
regardless of what therapy they get.
80 kilometres is a long way though.
We've heard some sites feel the patients at their location are, if they're on a trial and they travel from a distance, actually there's some better support, or they have perhaps some access to other services or something that just makes it a little easier because they know they have to come on a specific schedule, a specific day, and maybe it's a little stricter in terms of follow-up. Has that been a problem at any of your sites in Czech Republic? Has that been how are patients managed if they're on a schedule and they travel to you from a distance? Has this been a problem?
I think it's a little bit easier for our patients because they get ambulance transport.
They get transportation to help them?
It's paid by the insurances.
Oh, okay.
Because if we are the only center in the Czech Republic which is giving that treatment, the insurance is compulsory to pay it.
Okay.
This transportation.
Okay.
So they get like a free taxi.
That helps a bit, yeah. And do you know at your site, some are in a clinical trial? Not clear, maybe? I don't know. You know
patients live
close by. Okay. Okay.
They're very small.
Yeah.
Yeah, Belgium is extremely small.
So small. Not an issue. Okay.
It's the thing I noticed in the case as well, like 80 kilometers. Would it be a problem for inclusion? And also, since because for me, sometimes for older patients, it's like, I don't want to have them come over too often because they have to ask their relatives to come, to help them to come over. And so I will often choose less intensive schedules for older patients, even if everything is close by in Belgium. But it's
So what would you offer this patient, since FOLFIRINOX is not
the
trial? So that's weekly visits for the trial.
Yeah, but like for pancreatic cancer, for me it's weekly visits, but you've pointed, well, for FOLFIRINOX is 2 weekly visits.
Correct.
So it's something you can think about as well.
Yeah.
Like, okay, you give them a more toxic schedule maybe, and they're far away at 80 kilometers. But on the other hand, they only, if everything goes well, they only have to come once every 2 weeks. So it's something you consider as well when you talk to the patient.
But then they're further away, and if they have a problem, then it's a little harder to get them back.
But it's, I mean, if I discuss treatments with my patients, I don't only discuss toxicity, I also talk about what means of their social status, if they have family and transport means and stuff like that.
Yeah, it's important for the patient.
Yeah, makes sense.
Yeah. Okay, so thanks. We're going to have a presentation by Martin on just to refresh our memories on the mechanism of the development and action of the TH302.
Very good.
Okay.
Okay, so what I'm going to do now is give you some spotlights on the development of TH302 and some highlights in order to give you a bit more basis to sort things relative to other compounds. So this is always linked with the story, and TH302 really is emerging from one of these stories where a few folks really tried hard to make the world better. That was in the 90s. They tried to think, how could we improve, how could we develop new compounds for anti-cancer treatment. So the question is how to target cancer, obviously. And initially these guys, which later on founded the company Threshold, which is initially developed the TH302, and which we are collaborating also in this trial. So initially these folks thought about targeting the metabolism of cancer cells, because that's one of the hallmarks of cancer. But during doing all this preclinical work, they realized that it was also probably of some help if they widened the search strategy, and they decided to also evaluate hypoxia. So why hypoxia? Well, hypoxia has been long known to be one of the most important parameters for prognosis of cancer. Hypoxia is associated with resistance to chemotherapy, resistance to radiotherapy especially. And some of you may know this famous drawing from Bob Weinberg, which was initially generated in the early 2000s, summarizing the 10 most important or most prominent characteristics of malignancy. They called it hallmarks of cancer. And although hypoxia is not within these 10 parameters, if you go into look into the more details of that, and an update was published 2 years ago, I think it was presented first at the Vienna ESMO conference. So all these parameters, more than half of these parameters do have hypoxia involved in the mechanism. Yeah, like for example, a tumor promoting inflammation, resistance to cell death. So generally, hypoxia is being recognized as one of the most important pathophysiological conditions driving cancer, driving the malignancy of a cell. What about targeting hypoxia with drug development? How might that work? So that generates a question, how would one screen early candidates, prodrugs, for hypoxia? And that was being done by these guys by a cell-based assay. They had a cell line which was tolerant to a couple of hours of anoxic growth. So if the cells are put for a couple of hours with decreasing amounts of oxygen, here between room air, which is roughly 20% oxygen, going down to 0 oxygen. And then reshuffling these cells to normoxia. And with such a cell-based assay, one can screen relatively large amounts of compounds. And what you see here is the reference curves obtained with the TH302 compound. So this was, so if you look here at the cell killing effect under air, you need roughly, this is 50% inhibition here, you need a bit lower than 10 to the minus 4 molar. This is molar concentration of the compound. Now, if you lower the oxygen in the air to 10%, 0.6, 0.1, you go left here, you see that the cell becomes increasingly sensitive to cell death, to killing by, this case, TH302. And the difference here from normoxia to 0 or very low oxygen levels was roughly 2 log scales. Yeah? So it was really impressive, and TH302 was one of the compounds which showed one of the highest activities in this assay. So this was one of the major findings in the early preclinical work when identifying. So when further developing a drug which might be active under hypoxic conditions, one of the big challenges you have is how to measure hypoxia. So hypoxia has been recognized since the 50s or so, as an important parameter in cancer pathophysiology, and measuring hypoxia has always been a significant challenge. So the gold standard for a long time has been to measure the level of oxygen within the tissues by putting small glass electrodes into the tissue and measuring differences between tumor tissue and normal tissue and so on. But this is a procedure which is relatively feasible in animal tumors, but which is not very feasible in human tumors. So the goal was to develop some soluble markers which would be able to visualize hypoxia, for example, in tissues. And this has been obtained, for example, with the example of a compound called pimonidazole. So pimonidazole was an interesting compound which was shown to be activated under hypoxic conditions, and which was then able to stain tissues, in this case here murine tissues of sample tumors. And with increasing hypoxia and increasing stain here, the color here is brownish. So this made it possible to investigate levels of hypoxia in tissues, in this case murine sample tumors. And what the researchers found was quite consistent with the standard models about how cancers macroscopically grow. Because, of course, for growth of a cancer, supply by blood, new angiogenesis is required. So here, for example, you have an exact tissue section with a blood vessel here and an area of necrosis here. And you see an increasing degree of hypoxia, which is pimonidazole stain here, until this border where even there's no staining because the cells were all dead, so they were not able to activate the dye, the pimonidazole here. So this forms the basis for the model, which is picked on here. So in close proximity to a nourishing blood vessel, the oxygenation is relatively high. Yeah, it's in the range of 5% here. And with increasing distance from the blood vessel, the tissue oxygen level falls down and gets what is described here with this more bluish hypoxic level. That's the basic concept about hypoxia in tumor tissue. And that much of that is based on the availability of a dye like pimonidazole. So how would a drug in this case, like if pimonidazole, be activated, or for example a TH302? How would that work? This activation in areas of lower tissue oxygen levels. Well, to make the story short, basically this is an oxygenation process, the reduction process, which is being disturbed in the absence of oxygen. So compounds like pimonidazole or like TH302 have a structure which allows them to spontaneously undergo a 1 electron reduction, which under non-oxic or relatively high oxic conditions is immediately back catalyzed to the original molecule. The enzymes that are catalyzing this back reaction have a much higher affinity and speed than these enzymes, but only in the presence of oxygen. And with decreasing availability of oxygen, the activity of this enzyme, which catalyzes this back reaction, decreases more and more, leading to gradual accumulation of first this radical anion, and this then leads to breaking here the original molecule into 2 molecules, into the bromo-isophosphoramide mustard, which is the active compound of TH302, and the remainder. So the bromo-isophosphoramide mustard finally leads to a DNA cross-linking, and by that to an interruption of the replication machinery in its cell death. That has been found to be true in all the assays that are looking at the biochemical reaction for that. So basically, this is the mechanism that is underlying the activity of TH302. So the point is here that the TH302 is an inactive prodrug, which is activated under hypoxic conditions to result in a bromo-isophosphoramide mustard, which then finally leads to cross-linking. That is basically the main idea about the hypoxia activation. So if one has established this type of mechanism in preclinical systems, how would that work in tumor models, animal models, for example? For TH302, what folks have done is they have taken a couple of xenotransplants, human xenotransplants in mice, and have used the pimonidazole stain to visualize the hypoxic areas. And you see here 12 examples of such xenotransplants, all from different tumors. And you see varying patterns of hypoxia and varying degrees. Yeah? Intensive staining here in circular areas, here in a more spread area, or you have tumors with relatively small and low areas of hypoxia and larger areas where no pimonidazole hypoxia stain is being visible. So if these tumors are being treated in vivo in the mice with TH302, what would the tumor growth look like? So that's been done. So for each of these, in this case 12 samples, the tumor growth curves in the mice have been determined, and that's what they look like in sort of a summary slide. And if you just take a few samples, for example, this first one here, H461, going back to the stain, so that is one of the tumors which shows a greater extent of hypoxia and more intense staining. Then look at the curves, so this is untreated and this is TH302 controlled, TH302 treated. So it looks like quite a reasonable effect. If you go to another one, let's take this one here, BXPC3. So this is one of the tumors which shows a less hypoxia staining here, so less or this one also here as well. And if you look at the growth curves, much less effect or even no effect of the TH302 in these models. So overall, when the folks tried to correlate the degree of hypoxic fraction with the degree of tumor inhibition in these murine xenotransplant models, that is roughly, that is what they resulted in. And this looks like could be some halfway linear relation between an increasing hypoxic fraction and an increasing anti-tumor efficacy of these in these murine models. That is just the basic highlights. And basically, at roughly that point, phase 1 development in humans of TH302 was begun. I think, but at this point in time, we could interrupt here and show the video, because the colleagues have developed a short video highlighting the mechanism of action. And I see Greg coming to the computer. That's one here, right?
All information in this video should be considered highly confidential and proprietary and protected accordingly. Viewers are prohibited from sharing or distributing its contents to any third parties. TH302 is currently under clinical investigation and has not been approved for use in the US, Canada, Europe, or elsewhere. TH302 has not yet been proven to be safe or effective, and any claims of safety and effectiveness can only be made after regulatory review of the data and the approval of the labeled claims. Proposed mechanism of action of TH302, a small molecule hypoxia-targeted investigational study drug. The highly disordered vasculature of solid tumors is typically composed of cells with varying degrees of oxygenation, depending on their proximity to the local blood supply. Oxygenated cells in normoxic regions are in close proximity to blood vessels and divide rapidly. Cells in hypoxic regions are quiescent and acquire mutations contributing to drug resistance and enhanced metastatic potential. Conventional chemotherapies target actively dividing cells in normoxic areas and cannot easily penetrate the hypoxic zones. These cells are therefore less susceptible to typical anti-cancer therapies. TH302 is a hypoxia-targeted drug that penetrates through normoxic regions as an inactive prodrug and is selectively activated within hypoxic cells. TH302 is converted to its active form, releasing the cytotoxic effector and causing DNA damage to the tumor cells and cell death. Preclinical data suggest that the cytotoxic effector may diffuse to areas outside the hypoxic regions to exert a possible bystander effect and possibly exhibiting additional anti-tumor activity.
Thank you. No, I go to the next slide. Sorry, no, go back here. So that was the point when clinical development was begun. And just to give you two slides, two main views on the first into man phase 1 study. So that was, of course, a single a monotherapy study with TH302, increasing doses from 7.5 milligrams to 670 milligrams per square meter. And the dosing schedule was week 1, 2, and 3 every 4 weeks. So like we have it now in the Maestro trial, similar to that. Basically, the recommended phase 2 dose for monotherapy came out with 480 milligrams. The trial has been published at several conferences and also in a peer-reviewed journal. The point I want to make right now is how further development of TH302 was shaped based on the first signs of efficacy from this trial. So basically, there was a trial in solid tumor in patients with solid tumors with no other treatment options, and interestingly, and there was some dose expansion cohort on the 480 milligram dose, so that explains why greater numbers of patients have been treated here. So there were a total of 36 patients with metastatic melanoma, and here 8 patients had shown tumor response in this phase 1 trial. For small cell lung cancer, 2 out of 10 patients had shown responses, and for 8 patients with head and neck cancer, 2 patients had shown responses. These response rates compare favorably with those reported by larger trials in these patient populations. So basically, that forms the basis why clinical development of TH302 was conferred further into indications like this. However, this is monotherapy. And of course, although there's clear signs of activity, of clinical activity in the monotherapy trials, it's clear that also from the mechanism of action of TH302, the really promising development for TH3 would lie in combinations with compounds. So if you had such a compound, which is activated in more hypoxic zones and maybe targeting preferentially hypoxic zones, how would you deliver such a compound? What would be mechanisms of or areas of interest for combination? Just to quickly comment on that, so that you've seen that sketch. So if TH302 would be preferentially acting on this compartment here in a tumor, obviously it would be interesting to combine it with agents that target this compartment here. And so that's obvious. That's many of the standard cytotoxics we are currently using in the clinics, yeah, like anthracyclines, antimetabolites. Lots of these are mainly targeting this compartment here. Also of interest is what if a blood supply is being decreased? Yeah? Wouldn't that lead to an increase of hypoxia? So combination with anti-angiogenic agents is also of much interest in the development of TH302. And the third one is, we click that, yeah, we have that, right. And a third one would be a combination with those agents that would enhance the DNA intercalating and cross-linking metabolism activities. This was the second category, and this is the third category. So a combination with DNA damage sensitizers. That's currently the main focus of activity of a combination, both in a preclinical and in a clinical way. And I just want to give you a quick highlight. I'm going to skip the next slides. Quick highlight on where clinical development with TH302 currently is. So focusing on 3 groups. Well, that's on this slide here. Based on this concept of combination, what is the best combination agent, and that together with the second important property, which is simply the property of hypoxic areas in the tumor. So which are tumors known to have especially high percentages of fractions of hypoxia. And here sarcoma is one of the candidates, pancreatic cancer is also one of the candidates. Lung cancer varies, yeah, but the combination of tumors with high hypoxic fractions together with a combination of cytotoxics, in this case standard cytotoxics used for standard treatment, has led to the focusing on development currently in sarcoma, adult soft tissue sarcoma, pancreatic cancer and lung cancer. So for soft tissue sarcoma, as Mark mentioned already, development is far advanced. Threshold has completed the accrual into a more than 600 patient phase 3 trial where TH302
is investigated as add-on to doxorubicin in first-line metastatic locally advanced soft tissue sarcoma. So we're also expecting the results from this trial for next year, and this will be very interesting to see how the effects of the compound in this combination here are compared to the effects that we may observe, may get reported next year for the pancreatic cancer and the Maestro trial. Pancreatic cancer, that's why we're here today. And just to mention that, this is, here is the pancreatic cancer summarized. This is why we're here today, the Maestro trial. Just to mention, as Mark mentioned already, the development to investigate the value of TH302 when added to the doublet of gemcitabine and nab-paclitaxel has also been started. So there is a phase 1 trial ongoing in the US trying to define a dose for these patients. Furthermore, not going into details, but just to mention, TH302 is being investigated in a couple of other indications like renal cell, melanoma, hepatocellular carcinoma, and in combination with various compounds. So, for example, sunitinib here, or sorafenib or pazopanib, based on the theoretical considerations I've shown you 2 slides ago. But this is all early stuff here. This is currently all in phase 1. Finally, just to complete these spotlights, I haven't commented so far on biomarkers. You've seen the comments on timonidazole. This is not feasible in humans. The general intention, of course, is to target, to try to identify soluble markers, preferably in the blood serum, of course, that would indicate either an increased efficacy and increased sensitivity towards TH302. However, there's also one alternative direction of research, which is asking the question, can we visualize hypoxia also in humans? And the availability of new technologies like PET may open the door to that, because it's possible to combine markers that show up with a PET detector with substances that are being activated under hypoxia. And I just want to show you one highlight on that, which is currently topic of intensive research. So these are 2 different patients, 2 different tumors. In this case, it's lung tumors that have received a hypoxia-activated and PET traceable scanner. Yeah, thanks. And the preliminary pictures that can be, preliminary information that can be taken out of these experiments looks like this. So a patient is being injected a tracer, and 1 hour later being scanned with PET. And these images may result in pictures like this, where you have tumors where a high degree of hypoxia is indicated by a shift of the signal towards the yellow and red spectrum, compared to tumors here which show only very low degree of hypoxia. So this is a vision that is available for drugs like TH302, that in the future we might be able to identify patients who have larger areas of hypoxia in their tumor. And of course, this is done baseline before treatment. You can also do that after 2 or 4 cycles or so of treatment, and then look again. This is associated with significant technical challenges, which have not been completely resolved. But within the frame of the Maestro trial, We are about to implement, well, not we are supporting that, activities run by Juan Valle and Harpreet Singh at Imperial College in London and Christie's in Manchester to do this type of imaging also in pancreatic cancer. And by that I think I would close this part here, and I think we continue with questions,
Sure.
right?
Any particular questions for Martin? Because I just have a question and then we'll take a break.
Excuse me, why pimonidazole is not available in humans? The staining, which seems to work very well in xenograph model.
So it has been tested clinically, and the results are not encouraging. So there's basically no benefit in clinical terms, and from an imaging point of view, you would need to biopsy. You would first need to give the pimonidazole to the patient, then biopsy the tumor.
Ah, okay. It's not IHC staining. It's no, sorry.
Yeah.
Okay.
No, you need an invasive procedure
okay,
then.
Okay, okay.
And here you don't need that. Yeah, you just inject the tracer.
Okay. Yes, of course. Sorry about that.
What is that tracer, and is it feasible that other places could get involved? It's really interesting.
I said that.
You heard the names I mentioned, yeah?
Yeah, I know Harpreet. I know Valle.
Yeah. So this is relatively early research.
What's the tracer?
HX4. That is HX4.
Okay, that means nothing to me.
Yeah, so there's other tracers.
This is a tracer which has been acquired by from Siemens by Threshold. It's belongs to the same company than TH Road.
Okay.
And it's going to develop now.
But you're only doing 2 centres.
Yes, because we need to have a synchrotron close to the patient.
Oh yeah, cool.
It's a major problem is the synchrotron.
Is it not? What's its half-life? Is the half-life only like half an hour or something?
Yeah, exactly. Yeah.
Okay.
Not possible.
That's very short.
Yeah, so currently we are limited to the centres that are.
Right. That's a shame. That's really interesting.
Right now you're trying to correlate this.
There is another center who has used that in the Netherlands.
Well, they are not doing that in the frame of Maestro.
But there is another center where we are trying to develop that, and we are changing. We are currently trying to find a way to be able to extend the duration of the images that we are able to get.
Yeah.
And to fine tune when we can, until when we can have patients with this tracer.
Yeah.
But we do have a center in Canada that's using FASA.
It's even more difficult for him to get patients there.
But just so you know, we do have there's another tracer as well.
Right. Yeah.
Really
So I guess along the same line, my question would be, clinically, do you think since we don't have a clear marker or imaging study to select patients well, are there clinical correlates or substitutions that you might use in terms of thinking or how you think about patients for various treatments? For instance, knowing how this drug is activated, do you tend to think it might be more effective in bulky disease or something of this nature? Is that something that comes into play when you're thinking about patient selection for therapies, location of disease? Care anything? It's just the presentation. If it's metastatic or a large unresectable tumor and the patient is eligible for the trial, then that might be a situation, but not any other biologic type substitution.
I do have a question about, that concerns imaging, but more regarding response evaluation. Whether you have, I don't know if I can ask it now or.
Yeah, that's perfect. This is.
Because you have had these completed trials, and I know that we're supposed to evaluate by RECIST criteria, but do you have any knowledge about strange responses in other tumor types?
What do you mean strange responses?
Strong?
I'll tell you why I think I've got this one patient that is on the study medication, I think, because he's doing well, and he has he has this these lesions become more and more cystic during the treatment, so they become more black and more like the things you see in anti-angiogenesis treatments as well. And I've had another patient, and that's it's one with bulky, with large tumors, large, not small metastasis, but large metastasis. And I've had this other patient with very small metastasis in the liver, a lot of them, that upon his first evaluation had lesions that became more cystic as well, but we saw more of them, so we had to define him as being progressive, although the patient felt much better and the CA 19.9 had dropped to half of what it had been before.
Wow.
That's a response.
That's, I know it's a response, but you can't. I mean, you see new lesions, you have to use the RECIST criteria. For me, it's a response, but it's not response according to RECIST.
Were they, so initially when the patient enrolled on the trial, they were solid lesions? And that was like, you confirmed that?
And there's new lesions.
But the new ones are cystic or solid?
It's lesions that you can see, because maybe
that you couldn't see,
maybe
but they probably were. It's a kind of response that you see on angiogenesis as well.
See that.
Correct. There's liver lesions that you don't see, but when they necrose, you see them.
Yeah.
It's interesting. It's interesting you're doing a study in GIST, because they obviously use CHOI criteria to assess response as opposed to RECIST. And you also get the inflammatory disease, which either doesn't change or can get slightly bigger, but the tumour markers drop and the patient's pain resolves, and that's also responding.
I know, but I've been talking
CT
about
criteria,
this patient, and well, finally we had to. So he's
Radmila, have you seen this kind of in your 8 patients on trial?
I feel like the first patient we had, first 2 patients, they progressed very rapidly, just like the primary lesion, and now we see more stable disease.
Okay.
The lesions are not so changing.
Yeah.
If you've got a situation like Karen's, I guess, where you've got what you're convinced is a response, but by the criteria according to the trial, it's a progression, you take them off trial. Is there any benefit in unblinding for that patient, or reviewing what they've been, etc.? Because if you're concerned that this patient, you don't want to take them off what they're on, because clinically you think they're responding. But how would you instruct them?
It must be something back to the PNG. These cases cannot.
Can we unblind that?
You're not unblind, but in that case, Karen, did you kind of escalate it up to?
Go up to
well, the thing is,
the problem really is here the protocol definitions and adherence to protocol. And once we have agreed to use RECIST 1, we probably cannot go beyond this appearance of new lesions.
But your concern is the patient sitting in front of you.
Yeah, but it's also the outcome of the trial, because if you have like a bunch of patients, if you have 10 like that, then it's gonna influence your results as well. So it's basically it's important to know that like this particular patient, for me, it's a response, although we had to stop.
And there were liver lesions, of course. And to be the devil's advocate, it cannot be some harm then to healthy tissue due to the drug causing those lesions.
We cannot exclude that. My point here would be to answer you, yes, in this particular patient, there might be a concern that you're talking about continuation, obviously, So my take here would be, okay, so far this is a single isolated observation, and we're very interested to hear that. Yeah, and we will be happy to take that further. But in terms of clinical science, 1 is nearly nothing. Yeah, that I think is also an aspect.
I'm not saying draw long-term conclusions from it. I'm saying what you do in that individual situation. Yeah.
Unless, as you say, it's actually happening on multiple.
Precisely. Then you.
But if your patient is going better and if your CA99 is decreasing, that means that you have an answer.
I know.
I mean, this is a point to challenge the current RECIST 1.1 definitions.
Basically, if you hear it again,
it's lesions which have not been seen at the beginning. It's not so rare.
But interesting, Karen. For me, I would just carry on the gem off trial.
Yeah, but the point being.
No, I know that. But I'm just saying, what are you doing with this patient? Have you? Because you would say, okay, I mean, this drug may be the absolute thing that has completely clobbered the cancer, but equally, with most novel agents with a backbone, the standard gold therapy is the backbone, right? So, what have you done with the patient? I would continue on GEM without off trial. I mean, and then that's what I would do clinically. This is all about clinical now. Get trial.
I've tried to keep him on trial, and I had this halfway permission, But then, things always happen a bit. I had to go away for a week, and then in the ward, they discussed the patient again, and they said, no, it's clear, definite progression. So they took him off the trial, and they started second-line therapy. But I had been trying to keep him.
Pet him?
Hmm?
I know you didn't probably baseline pet him, but you'd pet him.
Yeah, that's why the question comes into kind of.
It's
not. It's no. It's very
interesting.
No, it's very small lesions. It's really. I'm talking about a patient with like 5 millimeter lesions, all very small things.
So these may not have been may have been present, but not been visible at baseline staging.
Yeah, it's what you see in other tumors as well. So.
He has had an MRI at the beginning.
No.
Yeah.
A diffusion MRI.
Yeah, maybe. Maybe not.
If you have multiple, I think you. Yeah. Any new lesion.
Yeah.
Is a progression.
It's new. That's the difference.
Yeah.
But again, from that, what you're getting is, progression, but it's not.
No.
Your data is wrong.
Yeah. I mean, we're talking here about.
Well, no, that's what I'm saying. That's what you're getting fed back into the progressed at X months, but it didn't. It was responding.
So I mean, we're talking about discordant response. Yeah. So partially progression, partially response in terms of biomarker, for example. Yeah. Yeah. We know that this is fortunately not a frequent situation in clinical practice, but it happens also in other situations.
It's not infrequent with pancreatic cancer. Actually,
Yeah.
it's not that uncommon that the CT has to be taken. It has to be interpreted in the context of the clinical and biochemical findings. It's very common. So,
especially if you go for locally advanced, that's very hard to.
Patients progress, and the CRS is just recorded. It's the specifics of progression are not recorded, or they are. So new cystic lesions, would that be reported specifically? So perhaps some pattern.
So I haven't heard that before. Yeah. I'll take that and we'll try to find out more about that.
Okay, good point.
Dr. Farr, is there some concern, sorry,
No,
to interrupt you. Is there some concern of unwillingly targeting other areas where there's some hypoxemia, somebody with claudication or vascular problems, or have you heard about this in the trial or with that drug? Are you clearly targeting areas of hypoxemia?
So these concerns have so far been only hypothetical, based on these mechanistic considerations. That's one of the reasons why, for example, in the exclusion criteria for the trial, a severe COPD with hypoxygenation is an exclusion criteria. That's the reason for that. Practically speaking, you will see the side effect profile, and that to me it indicates that also other areas in the body, for example, the skin seems also to have significant hypoxygenated areas, and that may be the reason why typically skin lesions are a side effect for TH302. We've not had any sort of increased reports of situations linked to other hypoxic events, ischemic events like myocardial infarction, ischemic brain stroke. No, no reports, no hints towards that. And anyway, you would not expect an increased frequency of such events, but you would probably expect a higher degree of toxicity of these, a greater extent of, for example, ischemia in myocardial or in cerebral infarction. We have no hints for that.
So should we take a quick break, come back around the top of the hour, and then resume?
Yeah, very good.
Ik doe het toch een ding. Dus ik kan het me voorstellen, maar dat was zeer concise en mooi.